started. We would like to start with the surveillance thematic area this morning. And so we'll be inviting, you're welcome, the team for the external evaluators who are going to be managing and overseeing the surveillance technical area. And would like to invite the country team. Who is representing the country team? I'm sure somebody from NCDC. Please, round of applause as they come up. I see Dr. Montari, Yashe, who else? Okay, you introduce yourselves when you come. Okay. So when you come over, you'll introduce yourselves. So there are mics on the table, so I think what we'll start will be that we will get the external evaluators to please quickly introduce yourselves, and then the country team will introduce themselves, and then Muntari will start the presentation. Thank you.
Okay, good morning, ladies and gentlemen. My name is Henk Ormel. I'm the team lead of the external team, but for this technical area, I give the floor to Buba.
Yes, thank you. Good morning, everybody. My name is Dr. Buba Manjan, the lead for this thematic area. I'm from the Gambia.
Good morning, colleagues. My name is Tendai Makamure, and I'm the co-lead for the surveillance. I'm from Zimbabwe, Nairobi, in Kenya.
So good morning, ladies and gentlemen. My name is Dr. Muntari Hassan. I am the head of Surveillance Division, and I lead the Surveillance Technical Area. And with me is, please can you introduce yourself?
Okay, good morning, everyone. My name is Dr. Bola Lawal. I lead the Public Health Informatics Unit at NCDC. Thank you.
Good morning, everyone. I'm Dr. Sunday Makama from the National Veterinary Research Institute, VOM. Thank you.
Good morning. My name is Yashe Mandiati. I head the event-based surveillance and the community-based surveillance at Nigeria Center for Disease Control.
So can we have, no, this is not the slide. This is not the slide. Can we have the slides, please? Okay. Well, how do I? So thank you very much. As I said, my name is Dr. Muntari Hassan. I'm going to present the surveillance technical area, the internal assessment. So, can we go back? So, as a form of background, the surveillance system has been consistently, growing in the country to monitor occurrence of public health priority diseases and outbreaks, requiring early detection and with prompt and effective response. Okay. So as we're all aware, we have deployed electronic surveillance across the country in terms of surveillance outbreak management analysis system. And we also have our counterparts from the animal sector and environmental sector, also having NADIS, that's National Animal Disease Information System, and then the integrated national environmental health surveillance system when it comes to the environment. We have seen, a milestone in the rollout of IDSR across the country. From 2001 to 2010 and 2019, we have 3 reviews of our national IDSR technical guideline, which informs our policy and which is based on the IHR 2005. As at the mid-term in-country assessment, the technical area had reduced scoring to 2.1. So when we had the mid-term evaluation, we have seen a reduction in our score, D 2.1, which is merged with 2.4 due to more stringent requirement for subnational implementation of indicator and event-based surveillance. That was the mid-term JE. In general, surveillance has seen a rapid expansion, particularly of SOMAs from 3 states and 32 local government areas in 2017 to 37 states and 774 local governments in 2020 to capture indicator-based surveillance data routinely and for outbreaks. So this is just briefly the comparative view of the surveillance pillar. As we can see, JE in 2017, there were 3 indicators, and we had 3 scores on each. And this is what I was trying to mention, issue of the midterm score when it comes to early warning surveillance function. And then internal JE that was conducted, we scored ourselves 4 in the first indicator, which is early warning surveillance function, and event verification and investigation 4, and then analysis and information sharing still remain the same. So when it comes to the first indicator, we can see national strategy, guidelines, and SOPs for surveillance have been developed and are being implemented at the national and intermediate level. The surveillance system provides immediate and weekly reporting of events and all data with lab results integrated and integration between IBS and EBS. So we scored ourselves 4 because the national strategy and guidelines and SOPs are in place. We are all aware of our IDSR technical guideline. We also have community-based surveillance strategic plan in place. We have standard operating procedures for event-based surveillance and other guidelines or SOPs that are in place. We have immediate and weekly reporting of events available at all levels because, as we're all aware, IDSR technical guideline 3rd edition, we have 45 priority diseases right now, and then 25 are for immediate reporting, which we use surveillance outbreak response management analysis system to capture. And then we use mobile strengthening of epidemic response system, which is MSAS, to capture the weekly reporting. So laboratory results are integrated with surveillance data on SOMAS. So we are all aware that the lab results are being imputed into SOMAS immediately after testing, or if that's not done, it is done at the subnational level when the results are conveyed to the states. We have functional EBS systems, which include epidemic intelligence from open sources, Tata4, which is a local surveillance tool that we use in Nigeria, and then we have the phone call, the WhatsApp, and SMS platforms. There is integration between IBS and EBS. We have right now a SOMAS module on SOMAS that we're able to send signals to states, and then the states will be able to verify the signals and then offload it back into SOMAS. And as we're all aware, the IBS, also the case-based diseases are also reported on SOMAS. So some of the strengths under this indicator is availability of national guideline, the IHR technical guideline. We have SOPs for various epidemic-prone diseases. We have skilled health workforce, which include IHR health facilities training. We have conducted ISON, which is integrated training of surveillance officers in Nigeria. We have fellowship graduates, intermediate and advanced. Availability of reference and disease-specific laboratories. It's also a strength. Integration of One Health approach in early warning. Availability and utilization of electronic tools to detect and report events. For example, SOMAS and autovisual alert detection and reporting of multi-disease, which is used at the community level as pilot in 5 states. Yeah, so, and we have right now a national community-based surveillance strategic plan in place. Some of the best practices are rollout of IHR health facility training in all the local governments in 36 states plus FCT. We have the use of electronic IHR for surveillance reporting, which I mentioned earlier, which is surveillance, outbreak, response, management, and analysis system for immediate reporting. And we have mobile strengthening of epidemic response system for weekly reporting. And then there is also ITSON training that has been conducted across over 23 states right now. So areas that need strengthening, we are right now at the final stage of optimizing SOMAS. We need to have a complete rollout of ITSON in the remaining 14 states. I mentioned we have rolled out ITSON training in 23 states so far. Deployment of SOMAS to remaining health facilities, because right now we're working to deploy SOMAS. We're at the final stage of deploying SOMAS to over 5,000 secondary and tertiary health facilities. So I think areas that need strengthening is the primary health care facilities, which we have over 40,000 across the country. Then coverage of community-based surveillance. As I said, we have community-based surveillance strategic plan, and we intend to cover that across the country. So challenges are staff attrition, weak community detection, reporting due to minimal coverage of community-based surveillance, limited electronic reporting at the health facilities, especially the primary health care facilities, inadequate funding for surveillance at subnational level. So the second indicator is event verification and investigation. We scored ourselves 4. Its method, process, mechanism for verifying, investigating, and risk assessing detected events has been developed and is being implemented at national and intermediate levels involving trained personnel from multiple sectors. So we have mechanism for verifying and investigating risk assessing detected events has been developed and is being implemented at national and intermediate level. There's also availability of trained personnel for event verification, investigation, and risk assessment from multiple sectors, human, animal, and environment. We have guidance and methodology for event risk assessment available and in use, and information in risk assessment disseminated via emails and other channels. These are the strengths: availability of a strategic plan, EBS and CBS, multidisciplinary approach for verification and investigation of events. We have reports, World Organization for Animal Health reports, availability of a functional event management system that is CITAWare across the 36 states. We have SOMAS functional across the country, and we have SOPs, functional IHR structures, including trained staff, and effective data management capacities available across all levels. So areas that need strengthening, rollout of DBS to states. We are right now rolling out to 27 states. So we also have implementation of CBS across the 36 states, and FCT, we have rolled out pilot to 5 states right now. And with the completion and validation of community-based surveillance strategic plan, we are going to roll out to all the 36 states. I think that's the area that needs strengthening. Then strengthening of the rapid response team at the subnational level. Challenges: inadequate funding for surveillance activities, particularly for event verification and investigation at the subnational levels. Inadequate manpower at subnational level. So these are event verification and investigation. The priority areas are full-scale deployment of SOMAS to health facilities, resource mobilization and budgetary allocation for surveillance activities at the subnational level, training and retraining of staff on the epidemiological investigation, especially at subnational level. So the last indicator is surveillance data is received regularly and analyzed on some priority diseases or unusual events, often with delay. Data is shared across sectors. We scored ourselves 3. We are thinking of 4 because we have been having epidemiological bulletins for quite some years. And it's there on our website up to December last year. Because of some technical issues and the review of the IDS certificate guidelines, we had some brief period of non-production. But right now we have commenced. We have the latest epidemiological bulletin. So it's up to our dear external assessors to see whether we will now go to 4 because we already have it and it has been in existence for some time. We just had a break, but right now we have commenced production of the weekly epidemiological bulletins. We have the one for a week ago. So the justification for this is surveillance data is received and analyzed on majority of priority diseases and unusual events. Advanced analysis of surveillance data available such as geospatial modeling, time series, especially at the national level. Mechanisms are in place to link epidemiological and laboratory data through SOMAS. Plans ongoing for interoperability of surveillance systems across different sectors. That is NADIS, INS, and SOMAS. There's, however, limited data management capacities at the subnational level with delay in data sharing from these levels. So the strength for this indicator is regular dissemination of epidemiological bulletin across the country and internationally, dissemination of daily and weekly situation reports, availability of electronic tools for data analysis like SOMAS, and data sharing frameworks, agreement are available at subnational level. So best practice, availability of data analytics and visualization tools. We have data analytics and visualization tool, which is DAFT. It's real-time data analysis that we have with inputs from SOMAS, MSAS, and other data sources. We are working to make sure that DHIS2 and other data sources are also linked to data analytics and visualization tool, just like we are working to make sure that there's interoperability between SOMAS and other data sources from animal and environmental health sector. So currently there is no interoperability between the different systems across the different sectors, environment, animal, and human health, but we're working on it to make sure that they are interoperable. So priority areas is establish interoperability between these 3 areas, systems, that's the NADIS, the SOMAS, and the INS. Then we expand data analytics and visualization tool to all the states across the country and to develop a robust MIE framework that brings all indicators to one platform to reduce regular performance feedback to guide surveillance, multi-sectoral activities.
Sorry to interrupt you, 5 more minutes. 5 more minutes.
Okay.
This round up.
So these are the reference and supporting documents that we have: the IDSR Technical Guideline 3rd edition, IDSR training manuals, ITSON training curriculum, National Community-Based Strategic Plan, SOP for EBS, and SOP for data analytics and visualization tool. So these are the team members that worked on this technical area. Thank you.
Thank you very much. I think we'll now invite the external evaluators to take over and give comments.
Yes, thank you very much for that presentation. And I can see Nigeria is doing a lot, and you have done a lot. So, but like, can you go to D2.1, early warning service function, and you go to your priority areas. Priority areas, not the score. Priority areas. Areas that need.
Okay.
I'm not seeing it. I'm seeing myself, not the. Okay. Okay. Yeah, so we are saying optimization of SOMAs. Go to, this is areas of, yeah, this one is fine. This is okay. This is the one I'm looking for. No, go back. Yes, so we are saying coverage of community-based surveillance across states. You understand? So, and this is D2.1. I'm also suggesting if we can add integration between event-based surveillance and EBS, and also complete coverage for all aspects of surveillance at subnational level. No, go back. I'm not interested in the score yet. Let's go back to where we are, where I'm having the coverage. This one. These areas need strengthening, isn't it? It needs strengthening. Do we all agree that the areas need strengthening? So I'm also adding there that we need to integrate integration between IBS and EBS. Do you have that? We can also add that here. You understand? We can also add that here. And also, I think you have that one already. Coverage, coverage of all aspects of surveillance at subnational level. Do you have that? If you don't, you add that one also here. Do you agree with me to add that one here? So if you agree, then go back to the results. What is your score? You have 4. Can we read what is in 4? No, go to the first one. The first one. Good. So you have a score of 4 there. Can you check whether you have that?
Yes, I believe we have that because, number one, we have the national strategy in place. We have SOPs in place. And we have developed, and they're being implemented at both national and subnational level. For example, right now we have community-based surveillance that is functional across all the states, using the community informants. It is available. But what I'm trying to say is that we have a strategy in place, and we are now modernizing the community-based surveillance strategy. In terms of, we have 5 states now that we're piloting the use of multi-disease to visual alert detection and reporting. But what I'm trying to say,
not to waste time, just look at this properly.
Yeah.
But surveillance system provides immediate and weekly reporting of events and or data with lab results integrated, and integration between event-based surveillance and EBS.
Yes.
You have that.
Yes,
integration between event-based surveillance and EBS. You have that.
Yes, because the
and this, and across the board.
Yes.
Also subnational. Then go back to that, please. Then you need to change that.
So
go back to that need for us.
I think I understand the point, the question now.
Yes.
We have event-based surveillance being established.
I don't need further explanation. You already presented. I want you to understand that that section you put where you areas that need strengthening. Go back there, areas that need strengthening, so that we all agree. Yes, here. Are you contradicting yourself?
No.
You are saying coverage of community-based surveillance across states, which means it's not across the states. You need to strengthen that. We have to agree. If you agree, fine. If you're happy with this, fine. I cannot change it. You understand? And also, you promised me that, you mentioned that IBS and EBS are integrated. If you have that, we are fine.
Yes.
If you have that, fine. If you don't, think about it.
So what I'm trying to say is that across all the states, we have existing structure that community informants report, detect and report events. But what I'm trying to say is that we have also piloted, a more integrated community-based surveillance strategy that is using audiovisual.
Wait, piloted.
Yes.
Piloted.
No, what
we
I'm
all
saying-
know, allow me, my brother.
Okay.
Piloted mean we all know what is piloted.
Yes.
When you pilot, you intend, when it's successful, you intend to roll it out. You understand?
Yeah.
So you are saying you piloted. I'm thinking of a system in place that covers across the board. And you want to do that, it is here. Coverage of community-based across the board. If you have it, fine. If you don't, can we agree here? Think about
You
it.
want to say something?
Thank you very much, sir. So as regards the integration, we currently have a system whereby when events are actually picked up using our EBS, it's investigated across board from national down to subnational level, and result of such investigation is integrated into our IBS depending on the outcome of the investigation. So based on that, we can actually conclude integration between EBS and IBS across levels. So that's what I would like to add to that, which actually satisfy the criteria for level 4. However, the idea of talking about coverage as a criteria for you to remain on.
Sorry to interrupt you, Dr. Bola. There's a lot of noise in the background. Could we just keep the noise down, please? We're obviously not hearing the presenters with the constant hum in the background. Thank you.
Okay. So why we are still at 4, the requirement is for us to have integration of IBS and EBS across level, which we currently have. In terms of coverage of EBS or CBS across all levels, and we didn't see that as a criteria for us to still remain on 4, and hence why we stuck to that level. Then in terms of priority area, you mentioned integration between IBS. It already exists, and that is the reason why it wasn't captured as part of areas that need strengthening. I guess that came from you. Thank you.
You don't only need to train health personnel and the like. It should be multisectoral.
Yes.
Across the board to qualify for that 4.
Yes.
If you don't, think about it.
No, we have. Because
Yes.
we are right now continue to train people on in IDSR at health facility level, health facility training across the country.
But you told me that
and
you told me that interoperability is a problem.
You say?
Interoperability between different
Hello?
sectors is a problem.
Interoperability is different.
Hello?
Training.
I don't know if I can add 1 or 2 things on this. Hello, my hand. Okay, so in terms of this training and retraining, apart from the IDSR, we talked about the field epidemiology and laboratory training program. It is a One Health approach program that is ongoing at every level, involving the districts, the province, or the LGA DSNOs across the human health, animal health, and environmental health. And just like NFLTIP is in 3 levels, we have the frontline, we have the intermediate, and we have the advanced. The essence of using the retraining is continuous. You have to keep and keep strengthening that. So that is why we're using that. But in terms of having it on ground, we have that on ground. The ITSIN, we just conducted ITSIN across 23 states in the country, involving over 500 and something local government district surveillance and notification officers and veterinary officers, as well as the health environmental officers at the local government level and at the state level. Currently also, there's an ongoing IDSRL facilities training, and we do this annually. So that is the essence of putting the retraining. So we keep training and we keep building on that and retraining them. Okay. Interoperability is quite a different scenario from this. We share our data, like I mentioned yesterday, but in terms of linking the digital platforms across different platforms, it's the stage that is remaining, and we've already highlighted that as part of our priority actions. Thank you.
Okay, thank you. So can you go to the last one? Is it 3? That score is okay, I'm fine with that one. So the 2 up. Okay. Before I give my score, let me allow.
Thank you so much. Thank you for the brilliant presentation and all the work that has done into strengthening surveillance in Nigeria. And as has been said, surveillance is the eyes of public health. And you reported that the eyes were lying, a component of the eyes has been lying down since December. the reporting you said on the component, all this data is received regularly, analyzed for events, often with delay. Data is shared across all sectors. So we are acknowledging that there is some delay in sharing the data. There is some delay in the surveillance, full surveillance process, the analysis and information sharing. Is that, can you confirm that before I proceed?
Yeah, no, that's not. That's why during the presentation I mentioned that why we stick at 3 is because of the temporary suspension of production of epidemiological bulletins. It has been going on for over a decade. It is there in our website, but due to some technical issues and the review of the IDSR technical guideline, because the diseases have changed, we're trying to convey that we have to train the states and the subnational level before they will continue reporting. But now it is up and running. We have the latest epidemiological bulletin for, I believe, last week. It is weekly. So it's because of that bulletin that we say, okay, let's stick to 3. When we come here and we explain, this bulletin is now available. Maybe you may consider taking us to 4. So that is exactly, but we are just doing justice to ourselves to say, let's stay at 3, despite the fact that we know we should be at 4. But, I told you the problem we had, but right now that is resolved.
Okay.
So, yeah.
Thank you, but I think it will be difficult because one of the challenges for you to grow, you still reported that there's weak community detection and reporting on the challenges, meaning that it's actually not happening in real time because of the weak detection within the communities. And also going back to D2.1, all this feeding from D.3, the delays that are there, noting that there's a challenge in the community-based surveillance. And in this indicator, we are saying that event-based surveillance also is a key part of the community-based surveillance. So if this component is still weak on the community-based surveillance, and you have said also you have a draft CBS strategy, which has not yet been, I read it in your presentation.
So it's not draft, it's validated. We have a community-based surveillance strategic plan that is validated.
Yes.
2023, 2027.
Okay.
That, as a guiding document for community-based surveillance. Frankly speaking, community-based surveillance has been going on across the country. Is that we just want to harmonize and make sure that, we have a guiding document that will, gather all the components across the country into a one streamlined kind of approach.
So in our approach, how can we improve the component? Because I think EBS covers also community-based. And if there's a challenge, a gap in community detection and reporting due to minimal coverage as articulated, can we therefore justify saying that we have a surveillance system which provides immediate and weekly reporting of events with lab results and lab results integrated and integration between IBS and ABS? With these gaps and challenges, can we justify that? I understand they're in place, but is there no need for strategies to improve?
Yeah, so presently we have systems in place. We have event-based surveillance, we have indicator-based surveillance, a structured way of reporting, and it starts from the community, all of them. Community reports to health facility to LGA, LGA to state and national. The normal structured indicator-based surveillance is there. And then we have also
Doesn't mean that we don't identify areas that we need to strengthen. Strengthening a system is an ongoing process. No matter how, even at 5, you still have to keep strengthening that system. And that is the reason why we've openly come out with certain areas that we feel we need to strengthen to ensure that we are able to sustain ourselves at the minimum at 4 and move towards improving it to 5, hopefully. So that's why, despite the fact we are still at 4, we still have areas that we need to keep strengthening, which is an ongoing process. I don't know if Mr. Yashi has anything to add.
No, I think maybe just to add to what he has said, I think the most important thing here is the reports are coming from the lower level to the national level. We have the report. We've been pushing out our weekly bulletin report, but due to the change in the reporting structure for the IDSR, The reports are there. The bulletin has not been pushed to the public. So what we've just done now is the reports are there, but the bulletin is what we stopped sharing from December. That is week 52 of December. But because of the availability and the changes, we have structured the report now to accommodate the new reporting structures based on what we are reporting now, just to ensure that this report continues going up. And we know that we've started. We will continue to push since we've been able to develop the latest version of the bulletin, which is always available to the general public on our website, and we share with our partners to inform other decisions and make sure that everybody is abreast with what is happening. Thank you.
Just to quickly add, the weekly epidemiological bulletin is not the only means via which we disseminate information. We have our weekly, monthly situation reports across all technical working groups for COVID, for Lassa, for measles, yellow fever, diphtheria, and the likes. So the weekly epidemiological report is not the only means of communicating to the public what the surveillance situation is. We have other channels as well. Thank you.
Yes, so finally, I think definitely I agree that you are doing a lot, you understand? So, but the score 4, like you touch most of it. Some of them are about to be completed. Some of them are in process. Some of them need to be strengthened, you understand? So for that being the case, like the area for D2.2.2, you need to ensure training across the board, all sectors. Now, they need to be properly trained. That's a requirement for that side. For D2.1, definitely there should be complete coverage at all subnational level across the board. So you need to think about that. Otherwise, you look at, we need to look at the priority areas. Then, if you want to say they are fully completed and the like, then we need to revisit those priority areas and work on it. Understand? So the 4 scores should go 3-3. The last one, I agree with that one, unless otherwise. So I'm taking it to the external evaluators there.
You have to be very clear what you are proposing for scores and combine to the priority actions, and then you have to ask the external team if they have questions or are in agreement.
Yeah. Yes, so this goes instead of for D2.1, D2.1, the score could be scaled down to 3 because the process that you are doing is not completed for some of them. You did very well in some of the areas, but this score is such that it has to be completed so that you can move to the next one. So I will try to the external team as well.
Can I come in, please? Okay.
So the external team, if you have any question.
Good. So let's go back to the criteria. I think you need to show the team your weekly reporting of events, some of the documents, and the integration between IBS and EBS. Then they will have a better idea of why you think it should be 4. So this is a provisional 3, awaiting evidence to up your score. And it seems to me this is partly in the eye of the beholder because you sort of have it and it's pilot, but is it real and is it substantive and is it integrated into the system? When you're talking on the side, you'll understand this better.
I want to ask. So at the any comment from the floor? Otherwise, not about this course. Any other comment? No. So, you want to say so? Okay. So,
Okay,
what time is against?
sorry, could I just suggest, sorry to interrupt you, that we have people from the subnational level here. So it might be a good idea to hear from them, you know, what their experience is, either in support or otherwise. But then the other thing, I guess, also that it might be good is that we are really running out of time. I think that, you know, it would be good if we have specific people from the States, at least the subnational. Are there any specific people who maybe want to give some feedback?
May I thank you very much for your suggestion, but I have to keep the order of the day, and we are running out of time for this technical area. So what Mr. Richard Garfield was proposing, he was saying, as the team lead is proposing a 3, a provisional 3, we could hear more coming to a 4. Let's do this in a side event or in the field visit. So at this moment, we are here to finalize this technical area, meaning the technical lead is proposing scores, priority actions. It is to the national team to say, we agree, then we have consensus. If not, I am sending both of you to a side event, and there you can discuss how to move on. So for the order of the day, I would like to ask the team lead, can you give the priority actions and your proposed scores for the 3 indicators?
Yes, so we only talk about, now we go to D2.2, I'm suggesting the priority action for D2.2 to ensure there is training across the board. I mentioned that. And the score you have for that one, because it's a key involving trained personnel. Yeah, it's not having enough personnel. So for that being, you score yourself 4. So we need to look at that. So for us, we're scaling it down to 3. You're doing a lot there, but there is something, few things missing that need to be improved for you to reach to this level. Yeah, so we give a provisional score of 3 until proven at the side meeting and also the side visits. Yeah, so finally, what time is against us? And then 2.3, that one is fine with us. We are okay with that. Yeah, thank you.
May I ask you to give your comment on the proposed scores and on the priority actions?
Okay, so my comment is, with due respect, I think the first indicator is still supposed to be 4, but we'll discuss that at the side meeting because we have all it takes to be at that level, frankly. So any other information that he needs or the team needs, we'll definitely be able to provide. And for the last indicator, also, I still have a feeling that we can move to 4, but this is subject to our discussion at the side meeting. Thank you.
But excuse me, I'm not following you now. The final indicator, number 3, you are proposing a 3, but now you are proposing a 4.
Yes, because I mentioned earlier, even during my presentation, I said we want to be 3. We want to stick at 3. When we come here, you yourself may decide to give us 4 because we already have. Yes, because. Yeah, no, don't worry. Yeah. So we'll discuss that by
okay. Okay. I thank you very much.
Thank you.
May I ask your attention, please? Because this goes above the technical area as such. My conclusion of this technical area is that you have to go to a side event. You are disagreeing on the scores, and you need to finalize your priority actions. So I would like to ask, I would like to thank the national team. I would like to thank my colleagues for this topic. but you need to do more in a side event. As soon as you reach consensus on priority actions and scores, I invite you on the plenary to tell us what you have consensus on. I mentioned, and this is more in general, because we are at the beginning of the day, I mentioned to you to come back with priority actions followed by the scores. What we just have seen is a kind of a soccer match in the scoring. A 3 and you want to go to a 4 and then you go back to a 3. This is not the way we should work. We should discuss priority actions, that is the most important thing, and out of the priority actions you can see what is the most logical scoring. And it would be nice if we have consensus on stage. If not, we go to a side meeting. But during the day, we need to focus on priority actions because we can learn more about this than just on the scores. So I thank you all. I fully understand in the heat of the game that this is a nice game to go from a 3 to a 4, but we are focusing on the priority actions. You will do this in the site visit and then followed by the scores. Thank you for this chapter.
A round of applause. Thank you very much. Thank you to the surveillance team. Thank you very much. I think I'd like to, also support the team lead in really emphasizing the focus. So ultimately, I think it's as much as the scores are important, like he said, the priority action is really what is critical. So I'll suggest to the team leads, as you go through the presentation, you don't need to go through the scoring at so much depth at the initial stage. Please run through the priority actions, and then you can come back if you want to discuss the scoring in detail. But I think the meat of the conversation is really around the priority action. So I'd like to, without further ado, invite the workforce team. Yes? I think it's I think they changed it, but we'll have the food safety team come up. So the representatives from food safety, please come up, Femi, Steven, and the team. I will also invite the external evaluators who are representing and working on food safety to come up. So food safety, Femi, Steven, and the other colleagues. And as you come up, we'd like you to introduce yourselves after the external evaluators introduce themselves. So they will tell us who they are, and then you will introduce yourselves, and then whoever is presenting will have a go. At 5 minutes, when you have 5 minutes to go, please look that way. Someone was going to show you, flag a piece of paper that tells you it's 5 minutes. And please, when it's 5 minutes, be aware of it. And when it's 1 minute, I will tap the microphone. Okay. So over to the external evaluators to introduce themselves, please. Thank you. Please, can we keep the noise down? Thank you very much.
It's you to give the presentation.
All right, okay. I thought we were going to introduce yourself first.
Oh, yes, you're right, sorry. The external team lead of the technical area on food safety.
Let's hear it for Richard.
I don't give him the mic the whole day anymore. He don't need it.
Yes, I'm Dr. Guy Mulumodera. I am a colleague of food security. I'm from DRC, Congo. Thank you.
Okay, so good morning, everyone. My name is Femi Stephen with Federal Ministry of Health. I have my colleagues here. The table is not enough for all of us. We have from NCDC, INSICA, from Federal Ministry of Agriculture, Dr. Salome, and Dr. Zira from FAO. We also have some other colleagues from Environment and NAFDAC and other agencies. So thank you. So quickly, we run through a bit of background on food safety. Foodborne disease outbreaks and food safety events are substantial cause of public health events. We have a lot of diarrhea cases across the world, and they've shown, the last WHO report shows that 1 in 10 people suffer from diarrhea cases, and it's a public health emergency. Food safety technical area has seen a bit more attention. We've tried to ensure that we do some awareness to bring up attention for food safety. We also have the National Food Safety Management Committee that comprises of so many stakeholders. We'll also show you some of the list of stakeholders if you're interested. Now, we also have a food safety bill. It should have been assented by the previous president, but I think for one reason or the other wasn't assented to, so it's delayed signing, but we're awaiting the signing of that bill. We've also developed the National Integrated Guideline for Foodborne Disease Surveillance and Response, which has been validated by stakeholders, approved by permanent secretaries from the health sector, agri sector, and the environment sector. That has been done. Of course, to aid the implementation, we are also part of the InfoSan network. In Nigeria, we are part of this InfoSan network. We have focal points. We have the emergency contact point as well, across different MDAs of the country. So these are a list of stakeholders. We can also refer to them from the health sector, agri sector, environment, science and technology, trade, finance, presidency, and all others. So we also have professional bodies and private sector stakeholders as well within the food safety space. So the road to JE 2023, in 2017, we had a score of 2. We had one indicator then, and we had a score of 2. But in 2019, with the JE 2.02, food safety was splitted into two indicators. And then we had the score of 1 and 1, because we're a bit more stringent, and we had a score of 1 and 1. So since then, we've been working on how to improve our score. So this is the score. We've been told not to dwell too much on this. So for the 2 indicators, we have a new score of 3 and 3. However, when we look at our strengths, what gave us the reason to have those scores of 3? So in the indicator 1, we have a defined structure for disease surveillance and notification at state and local government levels within the human, animal, and environmental health sector. I think the surveillance team has already said 1 or 2 little things about that. So we've heard about the IDSR, SOMAS, the NADIS, and the INES. So what we are trying to do with the food safety space is not to reinvent the wheel. We are not trying to bring up a new food safety or foodborne disease surveillance system. So we are leveraging the current surveillance system in the country. So we are leveraging the surveillance system in the human health sector, the animal health sector, and then the environmental health sector. So the presence of national assessment of foodborne disease surveillance and response system, presence of a designated food safety InfoSan emergency contact point, I've said that. And then we have a list of 10 priority foodborne diseases, which also includes biological and chemical hazards. Then we have a presence of a foodborne disease reporting form, questionnaire, so at facility level where you can have questions. Then, of course, presence of well-defined steps to establish coordination for integrated foodborne disease surveillance. So we've also had that step in the integrated disease surveillance guidelines, how we said, that I mentioned earlier in the introduction. So all this also includes the guidelines for the 10 priority foodborne disease which will also include the response to alert and action threshold, as well as case definitions and possible food sources. So our best practices, we conducted a national assessment on foodborne disease surveillance and response. I think that was in 2021. The assessment is available. You can always read the report of that. So you know where we were in 2019 and where we are now. So the multisectoral food safety and laboratory personnel are routinely present during foodborne outbreaks. So when we have cases of foodborne outbreaks, we had one in a big one in 2021. So we had a multisectoral team that was formed for that, to respond to that. Then, of course, we have the National Policy on Food Safety and Implementation Strategy. This policy is a 2014 policy, but it's under review. In fact, the review process is almost completed. It's just the remaining validation for that to occur. So areas would need strengthening, developing a system for integration of foodborne disease surveillance across all relevant sectors. So we have surveillance risk assessments using integrated surveillance reports. This, if we have this, literally will probably be on level 4 or level 5. But we need to, so these are areas that we really need some level of strengthening. So identification and onboarding of more laboratories across the country. So currently we have national reference labs that are mapped for foodborne disease surveillance. So we have them in the human health sector, animal, the food sector, and then as well as the environment sector. So little challenge, we have some political will and all that. We have funding challenges, and we have, inadequate support from partners as well. So that is part of our main challenges. That challenge is cut across the two indicators. Now for 2.2, we have strengths. Again, we have for response, we have a committee called the National Food Safety Management Committee. They meet regularly. We had the last meeting, I think, in April, April, yeah. And then presence of a designated info-site manager, I've mentioned that. Then we have a World Organization of Animal Health National Focal Point for food safety in the animal health sector. Then, of course, we have case reporting, verification of reports. So we have protocols for all this investigation, traceback, and model press release for communication and all that. We also have presence of well-defined roles and responsibilities of stakeholders before, during, and after. So all stakeholders, for instance, within the health, and human health, animal health, environment, private sector, they actually have listed responsibilities. We can share that with you, that, that tells them what to do before an outbreak, during, and after, so that we can have an holistic response. So, of course, we have a definition of an existing, what a food safety emergency is, and we adapted a codex definition for that, which we use. Of course, at subnational level, we've established a food safety desk for about 70% of the states, over 70% of the states at local subnational level to improve our response capabilities. Then capacity building, of course, is an area of strength. Capacity building here doesn't necessarily mean we don't have capacity, but needs to be strengthened as well. We know in every sector you need to also continue to train your workers on the best practice that needs to be done. Of course, then we also have rapid information sharing and communication during food safety emergency. This needs to be strengthened. Probably if we are strengthening this, probably will be in level 4. But this may need some level of legislation for enforcement. So because there are some times you look at information sharing during outbreaks, it will be, they will tell you that, okay, I can't share this because we don't have, something that will, something legal, to ensure those. So we may need something in that bracket. So for priority actions, we have 4. So development of training guides or manuals for human, animal, environmental health sectors, for food-based risk, foodborne disease surveillance, response and management system. So we also have identification and onboarding of contact laboratories for integrated foodborne disease surveillance and response. Like I said, we have reference laboratories, but we need to onboard a lot more laboratories into the system.
You have 1 minute remaining.
Yes, I'm done. So capacity building of food safety, disease surveillance and response laboratory officers at national and subnational level. Like I said, we need more capacity building. We need more capacity building on that. Then, of course, the last one, development of a strategy for communication and information sharing with partners, stakeholders, the general public, and international organizations. So, as I said, this may need some level of legal legislation where possible. So again, these are supporting documents. They are available. You can have them, and then list of team members, multisectoral team members. So thank you very much.
It was a very nice presentation. So I have some clarifying questions. Early in the presentation, you described that the different sectors had approved. I wasn't sure what they had approved or how you can, what's the nature of approval?
Okay, so quickly, that's the National Integrated Guidelines for Foodborne Disease Surveillance and Response. So we developed that, we validated that, and it has been approved by all the major One Health sectors in the country.
What we from outside the country can't feel is, what does approval really mean? Did they receive it and say, yeah, okay? Did they consider it carefully? Did they debate it? Have they revised content of it? Does everybody know what's in it?
Okay, yeah, so we have a stakeholder consultation. The document was drafted. We had stakeholder consultations. The stakeholders looked at it, made comments, debated it. Then we, at our level, we are not the management. But then you also need to have some level of management approval. And that we also got. The management has also been informed, have been briefed at the Ministry of Health, Ministry of Agriculture, Ministry of Environment on the importance of this document. The other stakeholders also already know their roles and responsibilities when it comes to implementing the guidelines that has been developed and approved. I hope I answered it.
Yes.
All right. Thank you.
I think it's very, moving next topic, very illuminating that you started in 2017 with a 2, and then you went down to a 1, and now you've bounced up to a 3. Why did you go down? Why was it appropriate to go to a 1? And how have you improved so much that you didn't even just reach 2, but you zoomed past it to a 3?
Yes, so basically in 2017, when we were on a 2, we had, let me just flip to the presentation. It's like I'm not controlling it, okay? So now we had a 2 in 2017. What the JE tool in 2017 was requesting for us was to have a level of collaboration between stakeholders, which we had. I mentioned we have a National Food Safety Management Committee, and we even have that, we had it as at 2017. And by presenting that, we could score a level 2. But when the JE tool of 2019 came in, when we had the midterm JE, we couldn't, that was not the main requirement. There were other requirements. You need to do an assessment of what you need. You need to build your surveillance structure. You need to build your response structure. How are you working with InfoSan network and all that? So we didn't have all that at 2019. So that's why we're in 1 and 1. But now, between 2019 and now, we've tried as much as possible to push ahead and work as fast as possible with the help of the National Policy of Food Safety and also the collaboration with stakeholders to push us ahead. That's why we're in 3.
What has happened is, in the whole world, we are improving the tools. The first JE was unique, and there was lots of consultation, and it was revised 50 times, but we still didn't get it perfect. And there have been 2 revisions along the way of the tool. And each time the tool becomes a little clearer, a little more specific about the intention. And so sometimes the scores have to go down, which does not represent a loss of ability as much as now that you're asking very specific questions, we don't quite reach there. We are working on combined. So by the fall, you'll be able to look at all of.
I can hear you.
You'll be able to compare your information over time, but we don't have that yet for you. That will be a useful tool for your analysis, to be able to see over the years the comparison in time. The criteria now for P61, that the system includes lab analysis to assign etiology of foodborne disease or origin of contamination event, and investigate hazards in food linked to cases, outbreaks, or events. I'm sure you have some of this. I'm sure there are moments when all of this may happen. This is perhaps a criteria that needs further specification in a future edition of the JE, because it's not clear from what you've said how much you have of this. Is it a rare an exception to be able to identify a foodborne outbreak and go to investigate the source? Or at the national or subnational level, is this becoming common? Functionally, how much do you do of this?
Okay, so we as a country, I don't know whether you've been told, we have 3 tiers of governance. So it's a bit more complicated than some other countries. But at national level, we have laboratories that are stationed, national laboratories that are stationed, that's why I said national reference labs, that are stationed across the country in different parts of the country. So some in Kaduna, Kano State, Kaduna, Lagos, Enugu, and all that. They are stationed everywhere. And they are able to identify organisms or hazards in particular, whether food substances or human samples or animal samples, as the case may be, or even the water, sewage samples and all that. So they are able to identify those. They are accredited to identify those. So that's why I mentioned those. So we can do that. So when an outbreak occurs, say in a particular state at subnational level, usually they will request the support of the national. So the national goes there. That's why I said we also have a multisectoral team that supports the subnational to investigate when it comes to foodborne disease, to determine the etiology of it and all that. But we also have the guidelines to specifically say, for the 10 priority diseases, to say this is what we are looking for. This is how we are going to look for it. These are the food sources that are commonly found. So we can link them back to the food item as well. So that's what we have. So I don't know if you answered your question.
Yes, it did. Just one follow-up. Well, go ahead.
Well, I think this is important for us external team to understand how you are defining national and state. If there is, let's be pragmatic, if there is a food outbreak, something is happening in a state, is there a state InfoSan contact point contacting you? Or is there a national team going to that state? Or is there a team in the state doing the investigation? How are you organized in this?
Okay, so like I said, we leverage on the current surveillance system in place in the country. Okay, every state has some level of emergency operations center. Every state. So when there's an outbreak, whether be it foodborne or other type of outbreak, the EOC is activated, okay? And then they in turn report to the national and tell the national we have XYZ type of case, okay? And can you give us a support? The NCDC or the IHR national focal point can also clarify some of these statements, but that's how it works. So at the state level, we also have, that's why I said we have food safety officers also at the state level. So they too also inform, there's a communication channel between the state food safety officers and the national food safety officers as well. So they also inform, vice versa, the vertical communication to say this is what we are facing, this and that. We can give them support if we don't have to go there. But if we have to go there, we have a team at national level that can also go there to investigate and support what is happening there.
What I would like to get afterwards is review an example of a state-level outbreak and another one of the national-level outbreak, perhaps the one that you mentioned from 2021.
Yes, we have a report of that we can share with you.
We should see that to see that it's both the investigation, the identification of the etiology and the investigation of the hazard. For a score of 3, you have to have both finding what's going on and then getting to the root of what's going on. So we'll look for this evidence with you afterwards.
We'll share that with you. I think it's already with the NCDC team, so it can always be shared. Yeah.
Good.
That's
assuming that that's in place. I think you're right that it belongs as a score of 3.
Thank you.
The next one. Country has a national food safety emergency emergency plan with the designated InfoSan emergency contact point with a central coordination mechanism in place. I think the key words is that it's in place, that it's functional, that it's not in a plan in a document, but actually it's working. Explain to us what is in place on a functional level.
Okay, so we have the InfoSan emergency contact points. We have the focal points at various MDs. Dr. Salome is one of the focal points at the Federal Ministry of Agri. I'm the focal point at Federal Ministry of Health. The NAVDAC, National Agency for Food and Drug Administration and Control, has the emergency contact point. We, over the years, we've been having some level of collaboration or communication, even with the InfoSan Secretariat at Geneva. So when there's an outbreak, maybe in a particular country, say South Africa where they had the listeria outbreak, they inform us, we go ahead at our own national level to investigate. So they say, for instance, let me give an example. So when the listeria outbreak happened, so they contacted us with an email to say, so a particular type of lot of food items was imported from South Africa to Nigeria that may be affected. So the emergency contact point and the focal point went ahead to investigate those lots, pick them off the shelf to ensure that they are not being sold. And then tests were done, carried out, and information were sent back to InfoSan Secretariat. Same thing, for instance, the outbreak in 2021, like I said, we're also in contact with InfoSan. They wanted to be sure if it's something that will have been a spillover to, say, neighboring countries and all that. And of course, fortunately, it was not a spillover to neighboring countries. It was within Nigeria. So we're also in contact with them as well. So we have that communication channel that we've established as well. And of course, when it comes to mechanism for response, we have the National National Center for Disease, Nigeria Center for Disease Control, who also has a mechanism for. That's why I said for foodborne disease, we are leveraging the existing structure. So also has that, but when it becomes a foodborne disease issue, The emergency contact points, the focal points are all already involved as well, are already been called into action. And then a team from the national can say, decide if it's important to go to the states or to just support the states via any means necessary.
You described as a strength that you have well-defined steps for investigation. And I think that's key in having that response to be effective. So that's another thing we would like to see. Look at your
Definitely
plan of steps.
you'll get that.
And assuming all that's all in place, I think, again, that it does justify a score of 3. Yes.
Okay, thank you for the floor. Yeah, I don't know if I've missed something, but the communication strategy is really a key for food security. I don't know if you have established a communication strategy already or you are planning for, because really it's one of the priority.
Yes, so again, when it comes to communication, maybe risk communication, when it comes to outbreak of foodborne disease, we already have a model press release as well that we are able to deploy when necessary. So that's, I hope that covers the question. We also have, internal communications within the MDA. So like I said, we have the National Food Safety Management Committee. We have that official communication channel as well for any communications that are necessary at the federal level. Then, of course, with the food safety officers at the subnational level, we also have that vertical communication as well. Then again, if you look at the priority area of action, one of the issues we have is communication. I'm not controlling this. Yeah, okay. One of the issues we have, the number 4, is communication and information sharing. And that's one of the issues why we were not in level 4. Because we know we have some, that's why I mentioned that we may involve some level of legislation to correct some of this information sharing loopholes for foodborne disease, when it comes to foodborne disease surveillance or response, as the case may be. So that's where we are. Yeah.
On these priority actions, I also have a question. Your priority action number 3 is capacity building. And the structure that you are describing, having imposant contact points at several ministries, at national level, also at state level, you have 36 states. This means you need an army of professionals working for food safety. Are you having this, or is it a structure that you are describing, but in practice it's not in place because the people are not there?
Yes, so as every country will know, or every technical area will say, we have that challenge with when it comes to manpower. Capacity is important, so when you talk about quality and quantity. But we're working on it. That's why we are doing, currently we put it there, capacity building, but we are even doing it. So for instance, one thing that it's actually, we're discussing with a partner actually on Friday, we're putting a date for capacity building on exactly this. Hopefully we'll get a date on that before the end of the year to do some of these things. Because what we as a government want to do is to build capacity. But again, we also need numbers. We don't have enough numbers as well. But again, when you don't have enough numbers, it's better you build the capacity of the ones you even have. So that when issues arise or when there are events, you can easily call upon them and they will be able to do X, Y, Z that needs to be done. So that's our approach. We cannot, from our own standpoint, we cannot say we are going to employ 50 million people or 10 million people. We are not the president. So it's one of those challenges that are beyond us. So that is where we are. But the ones we have, we are planning to do more trainings for them so that they can stand strong when it comes to implementation of this area.
What isn't presented in the priority actions is what I would call the strategy of how to do it. It's easy to say capacity building because no one will ever say it's wrong to train people. But who needs to be trained first? Who can you reach? Who's key? At what levels? And then what would be the second level? Can it build on FETP? Are you talking about primary care centers? Okay. There are many questions in here. We'll make some recommendations, but let us talk also to identify. I think you have ideas about the first steps and the second steps, but we want to pull this from you.
So like we said, if you look at the number one priority action, and want to develop training guides for both the human, animal, and environmental health sector. So we're looking at public health officers at that level. So for instance, in the human health sector, we're looking at clinicians, we're looking at nurses, we're looking at pharmacists, we're looking at community health, environmental health workers, and all that. When it comes to the animal health sector, we're looking at veterinarians, we're looking at paravets, we are looking at animal health officers, animal health workers. So when it comes to the environmental health sector, we're also looking at environmental health officers and all that. So we've let me say we've itemized that, but it's a presentation. So we can't list everything in the presentation. So that's why it's like that, yeah.
A strategy would be if we have $1,000, who's the first group, the most important? Then if we have $50,000, what else can we do? Steps. The one thing I don't see in your priority actions, but you have said it above, it really is implied here, is to pass the bill, which will help to enhance all of these activities. So let me ask from the floor if there are other comments from everybody. I see a hand in the back.
Good morning, all. My name is Yaya Disu. I just want to also express my experience when I was working in the local government as the medical officer of health. That was far back, some years back. I was involved in the outbreak investigation of chemical poisoning of beans. And summarily, what happened was people were hitting this at various food vendors, restaurants, and they were collapsing. So what we did was we were able to call the State Ministry of Health, Lagos State Ministry of Health, and then we collected samples from the restaurants, and then we were able to trace where they bought the beans from the market, and then the Lagos State Ministry of Health also traced it back to Niger State, and they realized that it was chemical, it was beans that was meant to be in the store. It was not the time for it to enter the market. And then that way, we're able to confirm the chemicals, as in through the laboratory testing. So samples were collected, and then they were taken to the lab, I think NAFDAC, and also Lagos State University Hospital laboratory. So they were able to confirm them. Just to let us know that at the subnational level, we also have systems that can quickly respond and link with national report and then get support from national. And that happened over 10 years ago. So I believe there should be some improvement now with a lot of coordination, better coordination we have now. Thank you.
Thanks for that. May I ask, does the international external team have any comments to add? Not seeing any, I think we can say that we provisionally agree with your scores. We are looking for some of the information to substantiate it, and we will think with you about specifying priority actions further.
A round of applause to the team as they round of applause to the team as they find their ways back to the chairs. Should we score them, or should we send prayers to their mailbox? Which one should we do? We should send prayers to their mailbox, Abi. Okay. We're going to invite the...
Human resource. Human resources.
So we're expecting the human resources team. We're inviting Dr. Fatima Saleh from NCDC with the rest of the colleagues, Dr. Shakir, and others to come forward. Thank you. A round of applause as they come up. I encourage them to come up very quickly. Same process, we'll get the external team to introduce themselves, then you will introduce yourselves. And then please, when it's 5 minutes, I have an assist. Somebody's going to flash the number for you, 5 minutes. Please look out for that. And when it's a minute to go, I'll tell you it's 1 minute remaining. So thank you. Where's the mic for him? Okay. Where's his mic? Okay. So we'll invite the... Where is the mic?
Okay, Dr. Agogo.
Yes?
Come here.
Okay, okay.
So can we...
Okay. There's another. Is that the mic? This one?
Want us to see?
Can we?
Yeah,
Let's
so
just-
I've got 1 hour, 45 minutes. They've agreed that. How many secretaries?
Only this one. So we'll go for tea break. Please, apologies for the delay. We started about 30 minutes late. So let's take this one and then we'll go for tea break afterwards. And just like we had a very slick presentation the last time, we'll have another very slick one. You promised to make a slick one so that we can finish and go for tea break, please. Yes?
At what time we need to be back? At
So
what?
tea break, please, will be very strict. Tea break will be just for 15 minutes. Okay? It will be very business-like. So 15 minutes, quick in, quick out, so we can move along very quickly. We started late this morning, so please let's try and catch up.
Thank you. Okay, good morning, everyone. My name is Fatima Saleh. I work with NCDC. I lead the technical workforce development and occupational medicine and spatial programs and projects. With me are my other team members. May you introduce yourself?
Good morning. My name is Paul. Paul Irabo is my name. I'm the technical advisor on workforce and human resource for UKHSA IHR strengthening project. Thank you.
Good morning, everyone. I am Olohitaro Udohai from the Public Health Department from the Surge Workforce Secretariat.
So I'm Mohammed Shakir Balogun. I work for the African Field Epidemiology Network. I am the FETP resident advisor.
If you permit, we introduce ourselves as well, the team lead of the external team.
Hi, good morning. My name is Sarah Amami. I'm the lead.
So we are going to start. For the workforce technical area, as I've mentioned, my name is Fatima Saleh. These are some of the abbreviations we are going to be using as we progress. We all know, it's a fact, that there is no health without a workforce. And there is no health security without a health security workforce. And we also know that developing a functional and sustainable public health system requires a highly qualified, competent, and well-motivated health workforce. Nigeria has well-trained public health professionals
The Nigeria Field Epidemiology and Laboratory Program graduates, we all know the key role they played during the Ebola outbreak in Nigeria in 2024. They serve in diverse roles and hold different responsibility across ministries, departments, and agencies. They were very notable, as I've mentioned, in interrupting the transmission of Ebola virus, the polio, and our recent COVID-19 pandemic. They remain a huge resource, we all know, for the Nigeria surge capacity, which the WHO has just flagged for the country. However, resilience against massive public health workforce such as the COVID-19 and the likes require not just a public health workforce alone. You need to have a roadmap. You need to have a strategic plan for this health security workforce so that you have the right numbers, the skill mix, and the right reach and access in terms of quality for them to be effective in their roles. So that need for a comprehensive workforce strategy was actually identified as a huge gap in 2017 during the first JEE. The NCDC has successfully advocated for incorporation of the public health security workforce in the National Health Workforce Strategy. So the National Health Workforce Strategy that has been launched, we could see that the public health component has been streamlined, but a detailed strategic plan has not been factored in, and hence the development, or rather coordination by the Nigeria Center for Disease Control and Prevention to coordinate the development of the public health security workforce strategic plan. So efforts have been made to map the human resources for health workforce, that's health security workforce at the national and sub-national. So at the initial stage of developing the health security workforce, because we've mentioned the overall human resource for health strategic documents and work plans and all of that has not really robustly, captured the public health workforce. So that was why for developing this, a key activity was actually conducted to map for the first time the public health security workforce, which is part of what led to developing the plan. So the technical area had a reduced scoring. Initially, it was score 3, but again, issues around sustainable financing for the health care delivery system has actually hindered the continuation, or rather sustenance, of the training, the FETP training as it were, and so we had some delay in the frontline components of the FETP training. It just resumed this year. That's specifically the integrated training for surveillance officers in Nigeria. We all know at some point we had a hitch, and that was not sustained. We are back this year with that training. Again, the intermediate FETP, as we've all had even before now, that also has kick-started. It started in 2021, and as we speak, the cohort 2 in training, about 32 of them. The e-survey, that is the animal sector kind of replicate of the FETP, that's the in-service applied veterinary epidemiology training, has also kick-started. And as we speak, it's in its 5th cohort, and those are the number of participants per cohort. We have a lot of fellowships ongoing around different thematic areas, the AMR, the mathematical modeling, the improving public health for action, which targets mid-level and senior level public health managers, and as well as the infection prevention and control. These are just to mention a few, to say that a lot of institutionalization of this public health training are currently in place. But the disproportionate distribution of such human resources across these areas between the national and the subnational level remain an issue. I mean, in terms of adequacy, it's still an issue. Sustainable financing, I've mentioned, is still a challenge. So these are the stakeholders for actually implementing anything around public health workforce for Nigeria. The Federal Ministry of Health, the Department of Planning, Research and Statistics houses the Human Resource for Health unit. So we are working together, and the rest of those key stakeholders, just so to mention the AFINET, which has been the key technical support for all what we are doing around workforce, and the USCDC, of course, the funding and the technical support that we all had. So in terms of the strengths we have for the multisectoral workforce strategy, which is the first indicator, is that we have a multisectoral strategy that has been developed, which includes a broad range of professionals that are required in public health. Because we have said the mapping, the current human resource profiling done has not really adequately captured the public health aspect. So, and that is why this has happened. And we are trying to ensure all the cadres in the public health space are also being, taken care of. We have an available technical working group for the human resource for health, which also includes the public health aspect of it, which we are all working together, and we meet routinely to deliberate on some of these things. This strategy is supplemented by other documents focusing on specific professionals and cadres. We have also, we've mentioned that the human resource for health strategic policy, the plan is there, the human resource for health profiling, that document is also what we have also leveraged on, and a lot of policy documents around migration of the healthcare workers and all of that. And as I've mentioned, we currently, as we speak, we have available health workforce profile, domiciled in the Federal Ministry of Health. The best practice is the fact that electronic workforce database has been set up. Some years back, we're not having this, but we are happy to mention that this is in place currently. So for areas needing improvements, we are saying this workforce database needs a mechanism that should be, we'll be regularly updating it. And we are also mindful of the fact that the technical competency to do that, oftentimes it's been outsourced. So that is an area we are really desiring to strengthen. In terms of challenges, the strategy, yes, is costed, is detailed, as at the time it's been developed, but again, a very clear funding mechanism needs to be clear and captured. Poor collaboration, definitely, because it's always been the human resource for health. The concern, or rather attention, has always been in the mainstream clinical care services. So the public health component, very, structured as it should. So, and since it's something that is evolving, we feel we need to collaborate more in the spirit of One Health, talking about animal and environmental health sectors. The career pathways for epidemiologists remain an issue. And we're happy to say that in the developed public health workforce, that has some key, it's been mentioned with some key activities to be able to achieve that. Weak implementation of human resource for health policies and plans, we also admit that this is a gap. In terms of human resource for implementing the IHR, for the strengths, we have appropriate human resources at all levels. The front line at the very lowest level of care, the intermediate level of FETP and ESAVET and all of those fellowships, as well as the national level. That's the advanced FETP. It's a strength for us as a country because we've seen what they are able to do. Then availability of personnel across discipline, because public health is cross-cutting by nature. So you see a lot of cross-cutting in terms of our coordination and even implementation of our health security. Best practices is implementation of FETP appropriate to the functions of each administrative level. I've mentioned that. For areas that need strengthening in terms of the human resource for IHR is to develop and implement policies to address retention, because attrition, turnover is something that is an issue. So we need, and we're happy as a country to say that the migration policy that is being developed for the country has really factored some of all those retention guidelines and some of those things that should be done. Need to collaborate with partners to identify, of course, that's what we've been doing, and we feel that needs to be strengthened. Inadequate numbers and distribution of public health workforce, poor retention of the skill. When you train them, they move on to other areas.
We have 5 minutes remaining.
For the training,
for your presentation, please.
For the training of the workforce, of course, we've mentioned we had FETP in place, large number of tertiary institutions, training all cadres of healthcare workforce, and also the impacts and the surge. That's the strengthening the utilization of response groups in emergency is something that WHO just kickstart. Synergy is not so optimum. That needs to be strengthened so that we get the desired. So in terms of the surge, this is a very new indicator. It's evolving. There is a 2-year national implementation roadmap currently as we speak. It's been developed for the 6 states in Nigeria, and it's a multisectoral, multidisciplinary roadmap, implementation roadmap. The best practice is that the roadmap was based on scoping, mission, and the mapping of the workforce required to do that. In terms of areas needing strengthening, of course, it's just been rolled out, so that needs to be expanded to the subnational. And the active participation of Nigeria Center for Disease Control and Prevention as the National Public Health Institute needs to also be improved, given their role, and the mandate. In terms of challenges, there have been decline, we've mentioned that, of really that synergy of NCDC and the such, implementation stakeholders. That synergy is not really there. And clear funding mechanisms needs to be also. So for this indicator, for the multisectoral workforce strategy, we are saying we're at 3. And this is because the workforce strategy has been developed, and all relevant sectors and cadre have been mapped, and we are working together in the spirit of One Health. So for this indicator, we are confident to say that we are at level 3. In terms of the human resource for implementation of IHR, again, we feel we are at 3, and that is the reason, because we have all this scale across all the 3 tiers. We have appropriate human resource, and they are available in all sectors, in both national and the subnational. So again, we feel we are at 3. We've bypassed those first and second levels. For the workforce training, again, given what I've mentioned so far, we said we have regular competency training, capacity buildings across the One Health framework. And they are available and ready to deploy in terms of response to outbreaks and all of that. So again here, we feel we are at 3, given the obvious reason we've mentioned. This is a new indicator, the surge. In fact, we had a lot of brainstorming in this. At some point, we're in two. Some of the teams that have been working on this technical area felt we should be at 3 because there is a strategic roadmap for implementation, and work has started, implementation has started in some selected states. Again, this is what we scored ourselves. So priority areas for action is sustaining the FETP and all of those fellowships. The career pathway for epidemiology, we're having retention of skilled workforce. So a key way to really motivate them and retain them could be that by the time they have career pathways, that could really encourage them to stay and do the best they can. The public health multisectoral strategy, it's also supposed to be very clear in terms of funding mechanisms, and collaboration needs to be enhanced with other stakeholders, interagency-wise, and all of that. So these are the documents we reference. We have some other ones, but these are the ones put there. And for this work, these are the team members that worked on it. Thank you for listening.
I thank you very much for the presentation. We are a bit in confusion if we have our tea break now or later. Now, yes, that was. So I look to the moderator. I do not know where the moderator is. There.
Prepare for the questions that they're going to come to them, but we will have a very strict 15 minutes, please. It's 11:23. Can we be back? 11:24 now. Can we definitely be back? Should we extend it a bit to 11:45, please? 11:45, we should be seated. And we'll be taking the first questions from the panel at 11:45 start. If it's one person here, we will start at that time. Everybody who came in today, you should have the tickets. So if you have your ticket, it's labeled Tea Break Hall, wherever you are. If it's hall or wherever, it's on the ticket. So please use your ticket and go where you're meant to be served. And we should be very fast. And once you get your food, please let's not linger around. So up and away. Thank you. So 11:45, we will start very promptly. Let's call the meeting to order. We'll give. Okay. Hello, Sarah and the team. So, welcome back from lunch. Oh, sorry, tea break. Lunch is already on my mind. So, can we hand over the mic to Sarah and the team to please proceed with questions and feedback to the country team? Okay. Thank you very much. Over to you.
I thank everybody for being back in time. We will have several more technical areas to go before lunchtime. So I wish you all good luck. And I give now the floor to the team lead, Sarah.
Thank you so much. And thank you so much for the presentation. I was wondering if, to begin with, we could move to the slide on priority areas for action near the end, just as a basis for our discussion. No, thank you. So really my first question here is that you've identified quite a number of areas as priorities. And I'm wondering if I could press you, among that list, which of these are really the key, say, 4 actions that need to be taken forward in this area?
Okay, so thank you for the question. So for us as a country, the first bullet says sustainability plans for FETP. So it extends to other capacity building across. So we felt it's a key thing for us to sustain it because FETP, as I've mentioned, they've been really in the forefront in the control of our pandemics and outbreaks and emergencies. So I think it's one of our key priority areas. We're discussing. It's also key for us to have an advocacy group, the FETP and the likes funding advocacy group, within the national and leveraging on alumni and all of that to really come up with an advocacy package and note to see how we can forge ahead with that because they are very key. The career pathway is also key. Nigeria is the one that has the highest export of healthcare workers in Africa. So we can't sit on and look. We feel part of retention packages should also mean to come up with some policy or legislation or mechanism to have a career pathway for the FETP. We can now scale down to other public health professionals. But for now, we are prioritizing making case for the FETP. Again, in terms of priority, so I've mentioned 2 there that are really like our immediate next steps, so to say. The retention mechanism for addressing retention of skilled professionals is also a key thing we are looking at. These 3 things, it's something that is for immediate attention for us.
Okay, thank you. I'm just wondering if we could reformulate some of these priority areas. I'm hearing all of your concerns about sustainability about retention of the workforce, and I'm wondering if we could streamline these a little bit. But that's a conversation that we could have together. With that said, I think maybe it'd be helpful to go back to 3.1. And I just have a couple of clarifying questions on the indicators. My first is about the status of the multisectoral strategy. I know that you've developed it. Has it been adopted, and to what extent has it been implemented? Can you give us a little insight there? Thank you.
So thank you again for that question. For the strategy, to be honest, we had some hitches in implementing it, but we are desiring that by third quarter this year, we are going to start implementation. Because as I've mentioned earlier, we have not factored a funding mechanism for it. The costing wasn't so robust, so we had to redo the costing of the plan so that it's a complete advocacy package, and at the subnational, they could use that for their action plans and all of that. So by third quarter this year, we are going to start implementing. But we have it, it is ready.
Sorry, so its status is it is not yet implemented, but poised to be.
Yeah, so the newly developed strategy is an attempt to be more comprehensive, but there are some parts of the strategy that have already been implemented. For instance, the FETP, it's a workforce development strategy that has been implemented since 2008. But this is an attempt to be more comprehensive. And even the FETP that we have implemented at 3 levels has been based on the One Health paradigm, meaning you have human health, animal health, and we have incorporated environment as well. So we have ongoing strategies for workforce development, but this particular one is a more comprehensive thing. So implementation, so to say, has started for some of the things, but the new categories that have been included have not been implemented.
Thanks very much for that. We also had a clarifying question about what professionals are covered in this strategy. We're hearing, of course, about EPI, and I'm hearing also about One Health considerations. We're wondering about sort of risk communications or legal experts or any of the other professionals that are listed in level 2 here. Can you say a little bit about the scope?
So, yeah, thank you. So, yes, for the strategy, you recall I mentioned at the beginning that for the first time, we tried to map the public health workforce. In fact, we had to define and agree by all the stakeholders who is a public health worker. And by that definition, that is any person that is involved in health promotion, either because of professional acquisition, because of capacity, or the skills, that person is involved in things around health promotion, prevention of disease, and control of disease in a given population. So that person is qualified as a public health workforce. So we've forged ahead to map them. As I've said, the current human resource for health profile in the country is not so robust in, factoring the public health professional. So what we did is the mapping. The mapping was done across the 36 states of the Federation by the human resource focal points within the states. So 3 people were actually tasked with that activity to map the public health workforce based on the definition. And as I speak, the strategy has identified way over 25 public health workforce, including the risk communicators, the infection prevention officers, and the evolving public health career we're seeing because of the changing dynamics. So, yes, we've mapped public health professionals in the current strategy.
Okay, thanks very much. My third question on here was a little bit about the database the health workforce database. I'm in the correct spot here. And I wanted to ask you about what mechanisms would be needed really to implement that. I know you've noted that it needs some support for updating. It needs a better and more sustainable budget. Can you tell me a little bit about what you need in order to make that happen?
Yeah, so thanks again. This activity, actually, it's domiciled within the Human Resource for Health unit in the Federal Ministry of Health, which is our apex body. So for some of us from the Nigeria Center for Disease Control, we're actually filling that gap, to really streamline the aspect that concerns the public health workforce. But as I speak, that registry, so to say, is available, has been developed by, thanks to WHO and the other relevant partners that really supported that activity. But there is always room for improvement. Mechanism for really ensuring they are being updated so that you get on the spot data of the current available health workforce. I think that needs strengthening, as I've mentioned. But in terms of the registry, yes, it's been developed and is functional, but needs to, room for improvement.
So the electronic database is already there, and the challenge is about updating. So we are thinking of how we can tap into the existing databases. Because for each profession, we have a sort of register that is maintained by a council. Let's say the medical council, for instance, the nursing council, and the rest of that. So we are thinking of a mechanism that can enable us to link these databases into this single one, such that you can have a database that you can look at and know the numbers, the distributions, and everything. So that's where the challenge is. So we haven't taken that step yet. That's exactly what we're thinking about, how we can tap into the existing databases so that we can update these comprehensive database that contains all the professionals.
Thank you, Dr. Shakir. Yes, so again, we have to admit the fact that we leverage on professional bodies to really take these talks for the health workforce for the country. So again, that may have a setback, but it's something that is needing continuous improvement, so to say.
Okay, thank you. I have no concern with the grade for this. Can I? Yeah. I wanted to go. Can I ask the general audience whether they have questions or comments on this particular indicator?
Thank you very much, Team Human Resources. My concern is that as we go across all the indicators, including this one, we seem to be concentrating on in-service training. And from even the stakeholders, I'm not seeing the ones that cater for pre-service training, the universities, the way by safety and by security technical area was considering. So is that something maybe I didn't hear and you're already considering that? Because for any sustainability of human resources, you need to think about where do they come from? Whether it's the paraprofessionals or allied professionals, whatever I call them here, but you need to think from the diploma level, certificate level, diploma level institutions, university level institutions, involve them as stakeholders so that at the end of the day, they are feeding into the in-service professionals. Thank you.
So, can I respond? Can I? So thank you for the question. So at the beginning, I've mentioned that it's a multisectoral strategy. So even the armed forces, the Nigerian armed forces were part of developing such a strategy. And again, the professional bodies, the training institutions, I'm not maybe exhaustive in putting up the stakeholders, but if you look at the strategy, it's a whole more than 1 or 2 pages, because in terms of even stakeholder responsibility, each and every one has its own the training institutions, the ministries of health, in the states, at the national, all relevant, including development partners. So in that, it's going to be public soon, so you could see that all has been captured, really. Thank you.
Okay, thank you, Human Resources for Health team. Quite commendable. I just want to have a bit of reflection on the score. I would quite agree with you on that. But thinking about the priority areas going forward, Nigeria is a large country. In fact, in some instances, it's considered as a continent or a subcontinent. And looking across the country, you could see different zones are experiencing different levels of stability and development. For example, the Northeast and the Northwest, these are purely humanitarian situations. You have the North Central that has a mix of both, and the South, mostly Southwest, that is experiencing some level of development. So if you are thinking about having strategies for improvement going forward, I think they need to be context specific. And then we also need to think about how we can engage the state governments, considering the fact that health is a concurrent issue, and the state government can make their policies and laws regarding how they want to improve the human resources for health. Otherwise, I think it's a good job, and I agree with you on the scope. Thank you.
So thank you again.
Can we keep the noise down a little bit, please? Please keep the noise down so we can hear the contributions. Thank you.
Yes, I agree with you, because if you also have a look at that document, you could see the parts of those activities also in the document is all this gap analysis, need analysis in terms of, because you need to have that stock before roll out any targeted training. So the strategy itself is around some 4 pillars, and education is part of it. And it's also factor things around how do you recruit these people, how do you bind them, motivate them to stay, and all of that. Again, in our SWOT analysis in the document, that's what you said has really been, echoed, because we could give a number of 4, 5, 6 states where even training institutions are not actually domiciled in those states. So you can imagine when WHO is saying, for instance, a ratio of doctor to patient is 600, when currently we are having, for that alone, we are having 1 doctor to 3,500 patients. So it's not adequate, and some of these states really don't even have such training institutions for healthcare workers. So everything is in the document. Again, it's not for me to actually go deep dive into the document itself, but your concerns has been actually captured in the document. But thank you for that. We could always improve.
Thank you. I think my colleague has a question. I'd like to give her the floor.
Thank you for your presentation. I just have a question under the reference and supporting documents for D3. The Human Resource for Health Immigration Policy has been in a draft form since 2022, just to know the progress for finalization up to date.
Yeah, so thank you. So last week, there was a validation meeting on that document. Stakeholders were brought on board to review, that's the final stage, and validate. So that document is going to really go to the public before the end of this year. Because as a government, Nigeria is concerned about the turnover of the health workforce. So it's something on the top, on the front burner really at the moment. Yes.
Thank you. I'd like to thank the members of the audience who contributed and to the richness of this discussion. In order to move on towards finalizing, I'm wondering if we can move to the priority actions, please. Could I actually first fine to stay right here. I'd like to pose a question about the number of FETPs in the country. I'm not sure that we had an actual number on that. Could you share that with us? I know that you are speedily training cohorts.
Yeah, so it's in tiers. We have the advanced FETP. As we speak, we have up to 11 cohorts that have graduated. We are also planning to have the 12 cohorts. So on the overall, we have over 400 FETP graduates. Dr. Shakir could say more on that. For the intermediates, this is the second cohort that we were training as we speak. We rolled out the first cohort last year, 2021, and the second cohort is now being trained, 2022. And as I said, it's a One Health kind of approach. The human, the animal, and the environmental sectors are actually the target for the trainings across board. Then for the front line, we call it Integrated Training of Surveillance Officers in Nigeria, the ITSN. That number, again, I think my colleagues should be able to say on that. But on the overall, yes, we are not having optimal number that we desire, because the aim is to have one trained epidemiologist for 200,000 population. So as we speak, sincerely, Nigeria needs over 1,000 epidemiologists to reach that. But as we speak, we don't have up to that. So that is why part of what we are doing is to work with other stakeholders. The WAHO, through the World Bank grants, are also doing things around epidemic surveillance intelligence for some local government workers. So a lot of partners coming in to really support the local government healthcare, that's the frontline workers. So by the time all these things are, harmonized, I think we are going to expand and get to the required number, so to say, so that we account for the attrition we are having. So the idea is to really see how we can expand this across the development partners and other NGOs, as we are saying.
Okay, thank you. And my second question about priority areas for action is whether there should be, given the challenges at the subnational level, a specific action that addresses next steps here.
Yeah, so part of the advocacy we feel, because that discussion has to happen, we are also looking at exploring within the One Health approach, seeing how all the MDAs, that's the environment, the agric, and the health, through their permanent secretaries, and also involving the Ministry of Finance and National Planning, budget, to see how this advocacy can be, made to them to factor it in their appropriation. That's the budget, national budget. A kind of budget item in their activities, because honestly, such trainings are resource intensive, And we can't rely on partners all this while, so we are trying to see how that can be made, advocated to these people, deliberately putting it in as part of their appropriation as they are, developing their work plans for different areas of their work. So again, it's that advocacy has to happen, and as I've mentioned, it's part of what we think should be done to see how these people can buy into this and we expand to get what we desire for the country.
Okay, so just for ease of translating the recommendations, I think I would perhaps suggest that in the final report, some of these are combined, those along general themes of retention and career path, perhaps we could combine. But with those, I'd like to ask if there are other comments on the priority areas for action, concerns, or gaps. Could I ask the external team, please?
I can feel that there is consensus between the national and the external team on the priority actions. They will be a little bit redefined and brought together. After having done this, Sarah will share it with you, and then you can have an internal comment on the fine-tuning of the priority actions. So I would say, I would conclude with there is consensus on the priority actions. Now, because time is running out, I would like to go to the final part, the scoring. This is the minor part, but still it has to be done.
Thank you very much. Yeah, so as I said, I'm content with the grade of 3 on indicator 3.1. Are there other comments from the external evaluators? Is it okay to move on to 3.2? Okay, for 3.2, we have marked that appropriate human resources are available in all relevant sectors at national and intermediate levels to detect, assess, notify, report, and respond to events according to IHR provisions. I'd like to open this to the external evaluators to ask if there are comments on this score here.
You are proposing a 3.
I'm proposing a 3.
I see nothing.
Well,
I'm not sure what appropriate means. If it means adequate, then you're not there.
So, adequate, okay.
I think it was a point that we debated. If the word had been adequate, it would have been very straightforward. We'll be thinking of numbers. But we thought appropriate meant, do we have the different categories of people needed to do that? So at the LGA level, the state level, we have the disease surveillance and notification officers that have been trained and are reporting through the IDSR system. At the state level, we have the state epidemiologists and the DSNOs that have also been trained and are doing this work. At the national level, you have the whole complement of people that you need to, conduct surveillance and respond to public health priorities. So we thought, given this distribution, through the 3 tiers and different categories of people, appropriate might be okay, and 3 is fine. But if the word had been adequate, yes, there will be a debate about do we have the adequate numbers and are they well distributed and the rest of that. So that was why we just thought, it's talking about do we have the kinds of people needed and can they do the work?
We do this all, and I think this is a good explanation. It also shows a little weakness of the tool. We have to redefine the word appropriate. If we are following Richard, then you have to go down to a 1, because appropriate is also there. And you are fully right. The team lead is proposing a 3, so I see consensus here. We move to the next. Please, for the order, Geoffrey, is it essential because we have to go on?
Yes, it is, Hank. Listening to the explanation that he has provided and the cadre of professionals that in their considered opinion should form part of the human resource, it is silent on the training of professionals who are supposed to address deliberate events of CBRN. So if that cadre is not available, then I would agree with Richard that the appropriate doesn't qualify, so probably drop to 2.
Yes, thank you for your comment. I think Sarah will describe it in her chapter how we come to a 3, but I would stick to a 3 for having consensus on this. You move to the next indicator.
Yes, given the ambiguity of the word appropriate, I think we move to the next indicator, 3.3, on workforce training. Here we've heard about the training and standards that have been disseminated and that they are available in selected professions, cadres, and sectors, and about the FETP program. I don't have an objection to the 3. This seems appropriate to me. I'd like to open it to the external evaluators for any other comments on this. Okay, I'm glad to see we have consensus. I'd like to move to our final indicator on D3.4. There we are. Okay, so I am assuming that the score that was given here was a 3, is that correct? Because we have a number in one part of the chart and a color in the other. Can you just clarify for all of us what level you would self-assign here?
So, again,
could you use the mic?
Okay, thank you for the question. So just to speak to this, the score, while we were during the internal assessment, we looked at the 2, so we actually scored ourselves 2 before we scored 3. So we scored 3 because we were actually already implementing activities on level 4. There is a rollout of the surge workforce in the states, which is a subnational region. And there have been a trained surge workforce, 82 people trained for a surge workforce. And they've been utilized for both in-country and internationally. So we're looking at level 4, seeing that we've started implementing some things on level 4. So we thought we shouldn't be on 2, we should be on 3, just to harness the things we need to finalize on 3 before we move to 4. So that's why there is a difference.
Understood. I'm concerned that given the background we heard about the issues you have with the surge workforce, which of these is more appropriate? Do you have feedback on that?
So the issues we have
with numbers, with actually getting the surge workforce in an emergency. That was my understanding from the background we were provided.
Okay, so like we said earlier, it's a new indicator and is a new initiative in Nigeria. So it just came into Nigeria in 2022, and we started the surge workforce in 2022, and we trained our first cohort in this November, December 2022. So when it comes to numbers, that's why we mentioned that we've just trained 87 surge workforce, and currently we've utilized 16 internationally, and we've utilized about 10 in country.
Okay, thank you. mean, given the stage of implementation, I would be more inclined to score this as a 2. Given that 3 would be post-implementation, I'd like to open the floor to the external evaluators. Sorry.
Well, to support the team lead and to support you as well. You have a good plan, but the full implementation is underway. If we give you a 3, your decision makers will say, okay, we stop doing this because it's implemented already. So to support you, I fully agree with Sarah that it should be better for you to have a 2. But I have to also look to my team. Are you in agreement with this? They are in agreement. So the external team is supposing to you a 2. If you agree, we reach consensus. If not, I have to send you to a side meeting.
We agree. 2 is good.
Very fine. With this, we reached consensus on the whole technical area. We reached consensus on the priority actions. They will be redefined, but that is between you and us. And we reached consensus on the scores. Congratulations and thank you very much.
Yeah, so thank you for your opinions and ideas.
As the team exits, and we can call on the next group. Well done. So we'll be having the health emergency management coming up. Dr. Benga Joseph, Fahad Mohammed, Rejoice, Luka Lawal, and Winifred Upono. Please come up for and then the team from the external editors. I would suggest you focus more on getting to the priority areas, priority actions. I think that will be really critical. Focus on the priority actions, focus on the... So you have 6 indicators, so please save up, just be very straight to the point. When it's 5 minutes, when it's 5 minutes to go, we'll let you know. When it's time up, we have 1 minute. So please introduce yourself. Maybe we'll get the external evaluators to quickly introduce themselves. Again, if you don't mind, Richard and Co, could you introduce yourselves? And then we'll get the country team to do the same.
Good afternoon, all. Permit me to stand on the existing protocol. My name is Benga Joseph. I will be presenting for this pillar. I would like my other colleagues to introduce themselves.
Good afternoon, everyone. I'm Rejoice Luka Lawal.
Good afternoon, everyone. I'm Dr. Fahad Mohammed from Preparedness Division, NCDC.
Okay, I will be taking us through these presentations on health emergency management. And this is the acronyms. Some of the acronyms that we use in health emergency management. Then, by way of background, health emergency management, as we all know, play a crucial role in ensuring that countries are well prepared and equipped to respond effectively to various public health events. and this will help to minimize the impact of potential health crises. Of course, several countries, including Nigeria, established systems to support health emergency preparedness, readiness, and response, and with different range of activities, from risk assessment, emergency operations, to coordinations of health personnel, research to inform decisions, supply chains to be able to support resource management. And collaborative approach is used to ensure that different sectors work together to achieve common goals. And this is under the premises of different regulatory bodies guiding different operations to ensure that everything is done according to the existing law. And this will help us to enhance overall public health preparedness, bolster its response capabilities, and protect the health and well-being of Nigeria. Now, the first indicator, emergency risk assessment and readiness, our strength. We have experienced and resilient workforce who have demonstrated the capacities in conducting the risk assessment both at the national and subnational level. We have the emergency management frameworks. We have multi-hazard preparedness and response plans, and several contingency plans to support the operations of some of the existing multi-hazard preparedness plans that we have in countries. We use technology to be able to drive some of this process by using technology to collect the readiness data across the countries, having a dashboard that everybody can look and visualize for us to see the readiness level at each level that will guide decision making and be able to develop high impact and cost-effective interventions to support both preparedness, readiness, and response. We also have interagency coordinations across different levels to support this. The major challenges are staff attritions, movement of staff from one place to the another just to secure greener pastures. Limited resources is still one of the challenges, especially to support some of those readiness actions that has been developed. We have a lot of complex geopolitical environment in risk assessment, and that impacts different requirements for different levels. Now, for us, our score is 3, but why do we arrive at this 3? The rationale behind this is that we have conducted multi-hazard risk assessment using STAR at the national levels, and then in major cities and some of the states at the subnational level. We also use this opportunity to develop the risk calendars, seasonal calendars, and then to also determine the impact and likelihood of some of those prioritized hazards. And this informs the preparation, the development of public health multi-hazard emergency preparedness and response plan using whole society's approach. Vulnerability risk assessment, risk mapping was also conducted. And we are also working to do that at the community level. Nigeria is one of the countries that first of all adopted the readiness tool and collect data both at the national and at the subnational level. Currently, we have the readiness dashboard that will soon be put on board that will guide what happened at the national level and the state levels as we prepare to respond. What are the priority actions that will help us to move to the next level? We need to review the multi-hazard preparedness and response plan, looking at some of the emerging issues, and then the current outcome of the strategic assessment at the subnational level. And this will also inform developing the contingency plan for some of the specific hazards that we have identified. Then conduct multi-risk assessment at the state level. Currently, we have covered about 6 states. We need to move forward to make sure that we've done that. We do that at other states, and then also support the community level so that they can have the understanding of the risks available and be able to plan towards that. Then again, we need to develop emergency preparedness business continuity plans. After we have identified all of these, what do we need to do to sustain the tempo so that we can continue to move from one level to another level and watch our back as we move forward? Investment in infrastructure to support emergency preparedness and response, conduct risk assessment in the remaining states, and operationalize the outcomes of the strategic assessment at all levels. Not just to have a document, but how can we make use of the seasonal calendar and risk metrics to inform further planning? The next indicator, public health emergency operations centers. Our strengths, streamlined coordination structures, readiness to act within 2 hours of notifications. The public health EOC can be activated. Establishment of subnational public health EOCs to ensure that we have a stronger coordinations, resource management, decision-making at the subnational level. Deployment of event management system, SIT-aware, and availabilities of comprehensive emergency response plan, such as different plans for different infectious disease, an SOP that guide the ways of operation to ensure that we have consistencies in order to be able to achieve common results. Our best practice is with public health emergency epidemic intelligence approach, day by day, using different technology available and subject matter experts to be able to review different data and be able to make and inform decisions on what needs to be done, even at different levels, both at the national, both at the staff levels and then the management level. Then multisectoral collaboration approach is one of the key in ensuring that there is enhanced coordinations at the EOC levels in order to support emergency operation. We have TR response. We have digitalized the POC operations. We have committed workforce, engaged partnership, ownership and accountabilities, regular simulation exercise to test what we have done before to ensure that we are ready and then to be able to give account to what needs to be done properly so that we can ensure that we do all things and achieve the desired target. And of course, one of our best practices to be able to evaluate and improve system, and this helps us to be able to ensure that we keep on doing what is expected and achieve the common result that optimize all our processes. Areas which need strengthening, harmonizations of digital tools, strengthening of subnational EOC, trainings and simulation exercise needs to continue at different levels at different levels, state and local governments. Cross-country experience sharing is also very important so that we can move to the level 5 and be able to support other countries. Then challenges, we have physical infrastructures. It's an ongoing thing. We have what we have currently, but we need to move forward to be able to optimize the structure that we have so that we can optimize our operations. Information and communication technology is also a challenge, needs constant upgrading, and then adding more, looking at evolution of some of these technologies that can help us to work faster and make us efficient and effective. Overstretched workforce, we have multiple outbreaks, and then many times there's a lot of fatigue in trying to cope to support different operations. Limited fundings, that's been a challenge to be able to have all the funds that is required so that we can move forward. So we believe we are at level 4, and the rationale that guide us to be at level 4 is that National Public Health Emergency Operations Center has been operationalized since 2017, and at the end of 2020, 37 subnational POC have been established in every state. We have subnational EOC, and then we have the SOP that guide the operation. We have the operation budget. We have the PAC handbook with full content and in place at all levels. We have national POC capability to activate and coordinate multisectoral emergency response to public health events within 2 hours. And for the past 5 years, we have activated IMS in 23 incidents. We have multi-level public health emergency training programs, simulation exercise, and network made up of nationals and state levels to network coordinations at all levels. These are key strategies next steps. 1, optimization of national and subnational EOC that take a lot of sub-activities that will help us to be able to optimize the national and subnational POC, like physical and infrastructure across all PACs will be upgraded with state-of-the-art equipment that can optimize POC operations. Strengthening partner coordination through government ownership. Interagency coordination has been very critical, and it's very, very important for us to be able to ensure that we leverage on every resources, we maximize every role and responsibility at different levels for us to be able to have a coordinated team. Expand revolving fund for outbreak investigation and response. This is critical for us to be able to ensure that we have funds that will help us to be able to perform all those daily activities and to support the EOC. Now, this third indicator, management of health emergency response. We have established our strength, established management systems, and that has been institutionalized and integrated at the national and subnational level. We have existing guidance on IMS activation, unified command and control system, common response framework, disease-specific technical working group that support the operations, availability of trained personnel and information management system in place. Our best practice is national outbreak review meetings. These are technical review meetings that look back, look at what is happening, take critical decisions, and provide solutions to the identified gap. And then 717 is another strategy that has helped us to be able to monitor efficiencies of outbreak response using timeliness metrics. Area which needs strengthening, training and retraining. Of course, as we advance, we need to make sure that we are abreast with different knowledge that will keep us optimizing our game in order to be more effective in performing our roles and functions. Continuous improvement, and then there is a need for us to be able to expand the strategies to further states. We have it at the nationals, and then in some states at the subnational level. Again, there is a limited capacity at subnational level. That's one of the challenges. We believe we are at level 4, and what are the rationale behind that? We have incident management system has been established and institutionalized at the national levels. The IMS is integrated with the national POC and is capable of supporting response at intermediate levels. The IMS was activated 23 times for multiple real-world incidents at the national level, and simulation exercise was used to test the IMS functionalities at subnational level. That is, as I keep pushing 1, 2, 3, and 4. IMF functionality was also reviewed during the after-action review and intra-action review. This is specific technical working group utilized the IMS structure to maintain an oversight on disease trend and watch mode. Incident activation plans, concept of operations, SOPs are in place to guide the operation of the IMS structure at different levels. Management of health emergency response. What are the priority actions? Advocacy kit to develop an advocacy kit for high-level engagement with decision makers at all levels. Integration of IMS to intermediate and PAC level, we need to integrate the IMS at the intermediate levels and at the PAC levels so that this same concept can be used even at the community level. Then exchange programs will also help us to be able to up our games. Then the next indicator is activation and coordination of health personnel and team in public health emergency. Strength, availability of trained multidisciplinary rapid response team, existence of guidelines for RRTs, availability of online modules for RRTs, best practices, RRT deployment rosters, standardized roasting templates, and post-development briefing. Strengthening of the area that needs strengthened, we need to strengthen the emergency medical team. We need to also work on the human resources allocations, trainings, and educations, while challenging the weak response structure at the subnational levels, resource constraint, and limited workforce. We believe we are at level 3, and these are the rationale behind this. National first responders, that is NFORS, are in place. Rapid response trainings have been conducted for frontline health workers at both national and state level. Such capacity exceeds at national levels. Then membership of regionals and global arrangement for deployment of such capacity during the local and international emergency, and availability of national RFT guide to guide pre-deployment, deployments, and post-deployment operations. Priority action, we need to develop comprehensive EMT plans. We need to revamp and establish such capacity at subnational levels, full deployment of the online RRT modules, cross-border collaborations, EMT and RRT simulation exercise for us to be able to test our capacity, our capabilities to respond during the crisis time. Emergency logistic and supply chain management, strength, capacity buildings across different levels, experienced workforce that have demonstrated this knowledge during different outbreaks. MCM plan is in place. Availability of offshore logistics system for us to be able to ensure that things that are coming out of the countries are properly received in line with the regulatory guidelines. Consistency in supply chain operation guided by adherence to relevant SOP. Best practice, preposition of response commodities aligned with the national risk seasonal calendars that help us to be able to do that so that we can guide the movement of resources to subnational levels. Multisectoral collaborations, foster on collaborations and coordinations among MDAs to ensure that we make use of the resources across different MDAs, third-party logistics, engagements of clearing agents, and then private partnership. Area that needs strengthening is warehouse capacity. We need to improve the capacity and storage capability, revamping logistic management, information system, capacity building, and then adequate funding to support resources acquisitions and management. Challenges, insufficient warehouse facility for both dry stock and then cold chain commodities, weak functional logistic management information system, weak logistic management information system, lack of end-to-end feasibility of stock, and overstretched workforce. We believe we are at level 3, and what guides us to say we are at level 3 is because we have the MCM plan in place, tested, and have the tabletop to actually test the plan, and that has also been subject to different, activations at different levels. COVID-19 is one of those outbreaks that help us to activate the MCM at the larger scales. A strategic stockpiling for emergency supply is maintained. The country has capacity to produce antibiotics, some range of PPEs, and some laboratory consumables. However, the woman vaccines are not yet being manufactured, but the process is still ongoing. There are no standing regional agreements on the procurement, sharing, and distribution of countermeasures. However, commodities are often shared with needy countries in time of emergency on ad hoc agreement basis. We have done that for several countries, done that to Liberia, done that to Ghana, and several other countries who have requested support from Nigeria. Plans are in place for procurement and distributions of animal countermeasure commodities. The priority action is to acquire farmer grain and non-farmer grain unified storage facilities to serve as the national stockpile, engage and train warehouse staff, strengthen interagency and regional collaboration to optimize resources management, optimize logistic management information system, and deploy to all facilities to ensure end-to-end feasibilities. Research, development, and innovations. Our strength, national research agenda has been developed. National Research Consortium is in place to guide development and implementations of research priorities. The countries has identified few institutions with research capacity within the countries, documentations of published scientific articles, and disseminations of lay research findings on NCD social medias and peer review. So our best practices, governance, multidisciplinary approach, promote regional equities and integrities, data sharing, areas that need strengthening capacity building for research personnel, fundings and resources, inclusion and emergency preparedness research in research frameworks, identification and collaboration with more institutions with research capability within and outside the countries. The challenge are listed: limited funding, brain drain, health system weakness, disease burden and emergency, and partnership and collaboration. We believe we are at level 2, and what guides us to say we are at level 2 is because institutions with such capacity have been identified. There is a national mechanism that facilitates and conducts regulatory review for research, including preparedness and response research. Although there is no national research framework for preparedness and response research, there is a national research agenda. We have technical working group that also support this. So the investment, the priority action for the research, investment in training program for research personnel and support mentorship initiative, increase government funding, strengthen local partnership, and develop adaptive research strategy for responding to health emergencies without compromising the long-term research efforts. Reference and supporting documents are listed, and then we have them like that. These are the members of the team. Thank you.
We want to hire you as our moderator and timekeeper and things. You went through 6 things very efficiently. And I will not be as efficient. But I take your model to try. Your biggest issue that I see that came up over and over is staffing. You talk about that you have adequate staff and you have EOCs set up in every state, but that the number of staff are declining. Why are you unable to keep staff? Actually, we shouldn't get into talking about this because this is the more general human resource issue. Your needs are not different than those in other sectors, but offline afterwards, I want to discuss some about the variations in the capacity of the EOCs in some of the more remote states or more limited states. But it's a remarkable achievement to have any ability to say there's an EOC in every state. That's a profound change from the last EOC, from the last JEE. And that is the level of response at which you need to have it. But then I'm a little surprised that the National EOC has responded to 23 events in the last 5 years. Basically, every 3 months, there is a response. About every 3 months that comes. That's not very many. I wonder how many are occurring at state-level EOCs, And I wonder why there aren't more responses at the national. We'll visit the EOC on Thursday. We'll be able to discuss some of this more. But I suspect that you should be having more responses. Part of your training needs you have identified, or your success, is in standardizing and making remote training available. This is a way to make it efficient. And you commented on the retraining, the value of maintaining a skill by doing retraining and simulations. Simulations are very good, but they're very expensive and they take a lot of time to organize. You also talked about after-action reviews and inter-action reviews. And I want to emphasize to you the opportunity to focus more on interaction and after-action reviews rather than simulations. You don't need to simulate events when you have real events. Nothing could be more sincere than learning from what your actual responses are. They are cheap and they are natural because you have them. So the point is to become efficient at doing them for every response so that they don't take a week or even days, maybe half a day with the key people. Operatively, every week during the catch-up, you can do some review. And maybe there are rare situations where you need a simulation, especially for cross-border, to involve people. But you should be inviting people from other countries to come to visit when you're doing a well-structured after-action review. And that's a good way to share. Use your natural events, and you won't need to simulate as much. But get good at it. And CDC US are good at this, and we can help you with this. You've mentioned 717, and this is, in the last year, has become a very popular phrase. We are all now interested in using a timeliness metric to see how we've done, how long it took to identify that an outbreak occurred, how long it takes to report, and how long it takes to mobilize a response. Your EOCs can integrate 717 in 5 minutes in every weekly update for every event that they're following. The more that these things are integrated into the response, the less that they stand alone with recommendations that are abstract. So integrate. Oh, I'm being brilliant, but he wants me to be shorter. We'll talk about all this more afterwards. And the key point on research then, one of the new indicators. There is a danger when you make research agendas with universities and things like this that they go into theoretical research. You actually, because you are involved in response to activities, you have applied research opportunities in every event. So to study the materials that you use to train people, to see how well people are retaining the training, this helps to keep staff and to make sure your staff are up to speed. Using after-action reviews in 717 is part of your research, internal research agenda to improve your response. My point here is that for action points, you need to develop the practical research agenda before you share it or before you give it to other people, or else they take it off in another direction. The purpose of research is to improve the response. To the degree that you can keep it to that, you get to lead. So I think your points on actions are very good. And we will just want to revise them some along the lines of some of these points that I've made here. You've mentioned to expand 717. I've suggested how in some way, and there should be a good deal of training here that, again, CDC US can help with for 717. I'm not sure what you meant by advocacy with politicians for the incident management. I understand training for incident management. And both that training and more of your other training can be done online so that it's standard across the country and so that it doesn't take that much time. But you have a research agenda in training to do. So please, if you could give us a word about expanding 717, about the advocacy and partnership, which are points that I'm not so clear on.
Okay, thank you. The advocacy in terms of the incident management structure to be able to ensure that at different levels, this is one of the culture that everybody use in responding to outbreaks. We know one of the goals of incident management structures is to ensure interagency collaborations and unified command systems. For youth to be able to have a unified command system across different agencies that have different mandate and role and responsibility, you must understand the concept of operations of IMS. If you understand that, you know that there are some times you need to remove the cap of the director, remove the cap and from this also agency, and take on the cap of emergency operation, whereby the same command system is obeyed at different levels and then be able to achieve the common result.
What I take from what you've just said is that the key aspects of advocacy are common training so that you have a common understanding across the different participants, and common after-action reviews so that you can see what you've done. Team, do we have comments and questions? You've bowled everyone over. May I ask, in the whole audience, are there some comments or questions? Okay, I see one hand.
All right. Thank you so much, Dr. Benga, for making this very important presentation. Just a bit of reflection and maybe highlighting some of the best practices seen across the country, especially at the subnational level. You may be aware that in some states, especially in the Northeast, public health emergency operation centers have been established to support the humanitarian response in the Bay, Borno, Adamawa, and Yobe states. And before then, the polio EOCs have been operating. So I think it's important to highlight that one of the important achievements and transformations seen over the years is the efforts by the national government to help in integrating this separate public health and the polio emergency operations center into the One Health approach. So that effort has seen remarkable transformation in the way public health response is taking place at the state level, and that effort is also being translated in other states where they have separate platforms, separate buildings, separate structures, separate staff or teams for public health and polio emergency response. So I think that is a remarkable achievement that needs to be highlighted and discussed going forward, and that can be replicated in other states. This is an example from the Northeast. It's a special area, and I think it deserves mention here. So thank you again, Dr. Benga, for the good work and the good effort of NCDC to support the state government across the country.
In many of the areas that we've covered up to today, Nigeria is at the level of we have the plan and we're starting to implement it at a subnational level. And in the National Action Plan, there were, I think, 500 some activities. So it was impossible to really identify. What's needed is strategy, like what do you do first, and then what follows. If I had the chance, 5 years ago when it was National Action Plan, I would have said the strategy is establishing EOCs in the states. Because if you have an EOC, then you can stimulate the surveillance, the coordination with lab, the coordination for One Health. That's the key institution, structure, and personnel to make the rest happen around it at the subnational level. And we see in this indicator that you have proceeded far ahead of some of the others, where it's not putting your toe in the water to see what the temperature is, but there is an involvement and an engagement at those levels. Now you have the opportunity to strengthen the training, standardize the approach, make sure that the standards are there for everything, and to focus more to make sure that the staff are adequate for these activities. But personally, I think it's magnificent. Knowing Nigeria and its development, I think this is one of the smartest things that's happened. I do not see a reason to disagree with any of your self-scores. Provisionally, until we visit the EOC, I am calling it provisional. Team, any issues? Particular concerns?
Okay, my name is John Oladejo, and I lead the emergency team. As a matter of fact, I just want to emphasize more on the advocacy which you just mentioned. You know, before 2017, we had only one EOC, just only at the national level. That was the time when we had our CSM outbreak, which was a very large outbreak in 2017. Immediately after that, so we had to decide to go on advocacy at the subnational level, because if you don't do that, you will not be able to achieve what we really wanted to achieve at that time. So we developed advocacy kits, then we went to all the states, and before the pandemic, we were able to at least establish EOC in 37 states, 36 states plus FCT. So that was exactly what he was trying to describe when he was talking about advocacy, which you actually rightly mentioned. So I really want to show some emphasis on that.
Thank you. I think we can let you go free.
Thank you very much. A round of applause. It's too late to say take a bow, but take a bow, eh? Okay.
Mr. Moderator, as this is going so fast, may I ask you in between, because there was reached consensus, so the team lead of surveillance, D2, can they come to the stage and to explain to the audience where they reached consensus about?
Where is the guy? Okay. Yes, so okay, you are done. So we had this side meeting, and then we are able to reach to consensus. So do I allow you to come first?
Okay, so thank you very much. I think we had a very engaging, discussion with the external assessors, with our team. As you are aware, we have 3 indicators under surveillance. The first one is early warning surveillance function, and we rated ourselves 4. But having discussed with them, and the issue of animal environmental components actually came in terms of surveillance at subnational level. So we unanimously agreed to step it down to 3. The second indicator is event verification and investigation. After discussion also, we scored ourselves 4, and we have also agreed to leave it at 4. Then finally, analysis and information sharing. Just like they suggested during the presentation, we are leaving it at 3, the way we assessed it. Thank you very much.
Yes, thank you very much. And I think he rightly mentioned it, and then the reasons are for D2.1, there is need for proper integration. D2.2, training on FETP across all sectors. So for that one, it captured across the board, and these are the frontline field workers, and also we have the intermediate, and you have the advanced level. These are key in surveillance, so we managed to leave it at 4. So for D2.3, instead of they mentioned it to increase it to 4, but after discussion, we realized that it should remain at 3 because of interoperability. They have to look at some of the various indicators, some of the various variables to be included in various data collection tools so that they speak, so that now you'll be able to capture. And with integration, you will speak because you come to understand each other. So we reach to consensus. Thank you very much.
Thank you.
The duet that they've just done. Thank you. So, if it's okay with the external team, we would like to invite the next group, which will be linking public health with security. And we would like to invite Dr. Damisa, who is the team lead from the Office of National Security Advisor, with other colleagues from ONSA, Mrs. Okoli, Dr. Iwawere from the Nigerian Navy, and Mr. Ola from ProHealth. So we'd also like to invite the external evaluators to also come up here. And if you see a military person come up, we are safe, right? I think we remain safe. So thank you very much. So if you come up, please, like we said before, please go straight to, as fast as possible. You have just, I think, one indicator, right? So please, as much as possible, straight to the priorities, and then start by introducing yourselves. Then or maybe we start with this time the. Okay, so the back is low. No photo. Laptop is not charging. Okay. So, can you introduce yourself?
Good afternoon, House. Standing all existing protocol. My name is Dr. Levin Damisa, presenting for linking public health with security authorities. And with me on the table to support is Mrs. Okoli Ifenwa, who is a desk officer and very wonderful, dedicated staff. And also Lieutenant Commander Iwari, representing the Nigerian Navy. So we have other people in our team from intelligence agencies and foreign service. In the context of national security operative, the NSA, in the strategic work, which we call the NSS, in our security strategy of 2019, has already captured public health threat as one of the threats to national security. In this context, it said, the global impact of climate change has altered the dynamics of disease patterns and incidences across the world, with resurgence of viral hemorrhagic fevers. We have Ebola, we have Lassa fever, then monkeypox, among others. We will continue to promote the ideas of IHR of 2005, which Nigeria is a signatory, while working with relevant agencies like NCDC, USCDC, and all of government approach to stem the tide. Our abbreviations are shown in the slide. They are quite easy to know. Linking public health with security authorities, overview. Nigeria has demonstrated capacity for linking public health during the past and ongoing public health emergencies at every point in time. Some of those that come in mind are the military effort in Ebola in 2014, which became the watershed of public health response. Involvement of our security forces in the response to insecurity and public health emergency in hard-to-reach areas in the Northeast during the polio program, by having personnel being sent into hard-to-reach area. And this issue of military personnel also came into use during COVID-19, in which the Pfizer single dose was reserved and used in hard-to-reach area with military support and military backing. Enforcement of law and order during lockdown and long-haul logistics during COVID-19 response are some of the examples of military involvement. In 2017, our JE, due to lack of undocumented MOUs, SOPs, and working procedure, the country scored low. We fell low in this regard. Subsequently, a lot has been done to address the identified gaps with involvement of NSA office and the preparation of the NAPS document, which was launched December 2018 by our former professor of health, as a Minister of Health, Professor Adioye. Key achievements in our TENCA area include, but not limited to, establishment of TENCA working group for linking public health, which is domiciled in ONSA, and we have our meetings as and when due. We have organized training on biorisk management and public health emergency preparedness. We have done joint capacity building in tabletop and full-scale operational simulation exercises on public health emergencies and disasters, testing event of deliberate origin, and this involved 28 MDAs. Other achievements in this area include development of unique protocols for security agencies and public health department to elaborate on specific roles during crisis, as obtained in National Crisis Management Doctrine, which was signed by President Buhari in August 2022. We have had medical incident commander course for medical emergencies during terrorist attack. We know that the Office of the NSA coordinates security in that regard, whether conflict from kinetic forces or non-kinetic forces. Then we have established a chemical, biological, nuclear, radiological, and explosive center of excellence domicile in ONSA with AU accreditation. We have introduction of sea-bearing element in counter-terrorism simulation exercise. Most of us from Nigerian ground will know that for the past few years, we do have simulation exercises. We have used Jabi Lake Mall. We have used ICC. We have used Sedi Plaza. We have used Silverbird Galleria. So last year, the one we used, train and the stadium, we actually introduced chemical, biological, we introduced chemical and radiological element into the conflict just to see how agencies will coordinate responses. It was a fallout of the response in the medical component that now gave rise to us having to have a medical incident commander course. We have collaborative development and signing of National Public Health Emergency Response Committee for point of entry, signed by the NSA. The key challenges militating this area is sustained funding. Now, these are part of our stakeholders, the NSA office itself, Port Health Service, Federal Health, NCDC, Quarantine, Agric, Immigration, Police, Defense Intelligence Agency, National Intelligence Agency, among others. Now, these are part of our, linking public health. We found out that sometimes, I think the NSA is actually prominent in most of the thematic areas like biosafety and biosecurity. In the area of countermeasures, we are also there. The reason being that, for example, NAPMA and NEMA, Biological Biosafety Management Agency, bioterrorism, biosecurity, all fall into the, when it becomes negative use, it becomes enough into the realm of terrorism. So eventually, the NSA's roles come to bear in that regard. Now, we have one indicator. Public health security authorities, easy law enforcement, border control, custom involved during a suspect or confirmed biological event. Our strength identifier is involvement of leadership of law enforcement and public health in air security issues. During COVID-19, you will see that the DGDSS, NIA, and many of us were prominent in the PTF COVID-19 response. That is a fallout of linking public health with public health authorities, with security authorities. We have access to a network of security intelligence personnel during any threat. The NSA has global reach, and so we have resources within reach. Then we have collaboration of relevant MDAs, including point of entry, with relevant agreement, policies, and documentation. Availability of human capacity for health security. Development of unique protocols for security agencies and public health department to elaborate specific roles during crisis. Sorry, my hand touched it. Establishment of Tinker Working Group, domicile in ONSA, which I chair on behalf of the NSA. We have had capacity building for public health personnel and security personnel on biorisk management. In this case also, we found out that bioterrorism is not under threat assessment matrix, and with human-man interaction, human-animal interaction with climate change, zoonotic diseases are becoming a threat. So we've had, and this has given rise to many laboratories, research going on. So we're actually handling the issue of biorisk management with stakeholders from the US and other people to train personnel. And a lot of training are going on in this regard, involving the academia, which to us is a significant milestone, bringing professors in biosecurity, bringing professors in virology, bringing professors under the ambit of the NSA, such that most of those researchers are now being classified as critical national asset for security purposes. Best practice identifier is the development of unique protocols for security agencies and public health departments to elaborate on specific roles during crisis, as obtained in the National Crisis Management Doctrine assented to by Mr. President. Areas that need strengthening is to develop and validate curriculum for incident reporting and joint investigation among law enforcement agencies. The idea is that these are areas that we need to build on so that we can have a validated curriculum for all, so that when it's being cascaded down subnational entities, what the content is uniform for a quick turnaround time. Then development of an annual plan for simulation exercises, which will cover full-scale simulation and tabletop, increasing funding for health security to strengthen capacity in quick response to significant health threat. Challenges here is the frequency of simulation exercises are not enough. The challenge, we want to make it more regular. Uniqueness of the command and control structure is also a challenge, but then unpredictable attrition of trained personnel in the sector. Many a time you train people, the next time they are not, because of career progression, you train people, the next time the officer has gone for training abroad. So that attrition is something you cannot prevent, but it's something that needs to be factored in. Now, based on this, we have level 1 to 5. Level 1 is no legislation, no relationship. Then we see ourselves as level 3, in which we have MOU or other agreement protocol that includes at least roles, responsibilities, SOPs, and information to be shared, exists between public health and security authorities within the country, and has been formally accepted to address all hazard. The National Crisis Management Doctrine, the NACTES, National Counterterrorism Strategy, the Terrorism Prevention Act, all are all legal instruments of government which empower the National Security Advisor to coordinate and to mitigate disease. So these instruments are in existence. So we assess ourselves as level 3 in that regard. The level 4 is there, level 5 is there. We are also peeping into level 4 when we have other issues addressed. Rationale for scoring our self-level 3, there's unique protocol for security agencies and public health department to elaborate on specific role during crisis as obtained in the NCMD document, and there's functional Tinker Working Group domicile in ONSA. Development area of priorities that are mapped area of priorities include to develop an annual plan for simulation exercises, full scale or on tabletop, to strengthen information sharing mechanism between civil, public health, and security agency through regular capacity building. This is anchored on the regular attrition between security agencies and in line with career progression. So then it needs to be strengthened so that those who are leaving the office can hand over the training to those who are coming. Another area of priority identified is increasing funding for health security to strengthen capacity in quick response to health threat, Establish real-time data viewing center at the Secretariat for ease of monitoring and evaluation of processes towards timely deletion, to support health programs with regular medical and health intelligence estimate. We produced a national intelligence estimate for medical issues some time ago. We are hoping to regularize it if we have appropriate funding, to develop and validate curriculum for incident reporting and joint investigation. So these are some of the instruments and references of documents which we say we have here to submit to the Secretariat. We have the National Assessment Doctrine, we have the report of biorisk management, we have the National Security Strategy, we have the National Counterterrorism Strategy, the Terrorism Prevention Prohibition Act, and the Draft National Action Plan on CBRLE 2022. Thank you very much.
Thank you for your presentation.
Thank you.
Let's dive deep into the discussions around this area. I would like to make a few comments before we discuss this technical area. Comments and clarifications. Clarifications that we would wish that every country that is making efforts towards strengthening this area would take into consideration. And like Richard had said earlier, this tool is a live document. We are using the 3rd version. It's still not perfect. So it's up to us to interrogate it and highlight some of the inadequacies therein. I say so because this technical area was conceived and designed to address exclusively deliberate events of chemical, biological, and radionuclear origin, and lately, of course, explosives and cyber. If you look across the 19 technical areas, and in particular this technical area, the 2.1, it fails to mention DE. It does not exclusively inform countries to focus on DE. The natural biological events are covered by R1 and R4. Accidental chemical events and radionuclear events of accidental nature are covered within the technical areas of chemical events and I think radionuclear events. So throughout the presentation, as I've seen it, it leans heavily on events of natural occurrence or probably accidental. I would like us to have that at the back of our minds as we discuss this. And the reason being, years down the line and based on the priorities that we'll agree on, we'll either miss it completely, the way we missed it before, and Nigeria was not the first, or we'll get it right this time round. Thank you. So I would like us to very quickly go back to your presentation. I just want to highlight a few things. One on the slide that is addressing the strengths within indicator 2.1. This may availability of human capacity for health security. It's ambiguous because we know that that is a very big area. So probably off the cuff, and we can discuss this on a side meeting, do you have evidence that Nigeria has human capacity for health security, specifically on deliberate events? Do we have people who have been trained on deliberate events to respond to chemical, biological, or radionuclear? You can park the questions, you'll respond to them. The next bullet is on establishment of TWG domiciled in ONSA. I believe that it has a TOR. I would like to put this on the parking lot because we'll be visiting the ONSA, so that we'll probably be able to see some documentation related to that.
That is not guaranteed yet anyway.
Sorry?
Visiting NSC is not guaranteed yet. Just go ahead.
Okay. Yeah. Great. So moving on, the next slide on areas that need strengthening, 2.1. There is development and the validation of curriculum for incident reporting, joint investigation, and information sharing for law enforcement. Those areas that I'm highlighting, I would like you to take note of them because we'll discuss them in relation to the priority actions that you'd wish to move the country forward. There is non-availability of standard curriculum for country-specific joint investigations. I'd like you to take note of that as well. And the next one, I don't know whether this slide is yours. 2.1, the next slide talks about strengthening the information sharing mechanism between public health and security authorities through regular capacity building for the identified focal persons. Please take note of that. Before I pass this to the floor and my colleagues, I have some clarifications as well that I'd like your team to make. One, there are so many documents that has been shared through the presentation. We've not had a chance to interrogate them. However, from where you sit and from what the efforts that the country has made, do we have specific documents, or whichever documents that we have, do they address mass casualty incidents? Do we have a document that addresses all hazards emergency, a protocol that addresses all hazards? Because if we look at the slide for indicator scoring, it talks about all hazards. It's not biological or chemical. It's not limited to radionuclear. It talks about all hazards. Do we have documents specifically linking first responders to relevant stakeholders, especially at subnational level? And then the component that has been silent throughout your presentation, the linking of the national security apparatus to the international community. I say so because in deliberate events, you will need to work with Interpol and other organizations such as OPCW, and probably even move it up to UNSGM. So are there specific SOPs that address that area, how Nigeria would seek out help from Interpol, OPCW, which is the investigative agency of the UN for deliberate chemical events? And because in deliberate events, the architecture is totally different. The response is different. The public health colleagues are supposed to be concentrating on alleviating suffering, but at the same time working with security apparatus to ensure the preservation of evidence that is then used by the security apparatus to attribute criminal culpability. And that is key for deliberate events. So those kind of documents or coordination structures, you need to demonstrate that either there are efforts to put them in place, or they are not there, or they're already in place. The area of capacity building, training for specific first-line responders for DEs is critical. You've mentioned trainings, but it focuses on other areas of public health, but not specifically addressing DEs. I think that would be all. If you can have the floor to respond, and then we pass this over to my colleagues, the experts, and then to the audience.
All right. Thank you very much. So I didn't get your name. I didn't get your name, sorry. Your name.
Geoffrey Jagero.
Thank you, Dr. Geoffrey. Okay, we were to meet yesterday. Actually, we couldn't meet. I had other crisis to attend to. Concerning the issue, you raised several issues, so I'll try to touch them all. The issue of deliberate event. What is there in the national constitution? Let me start that way. Like everything we are doing here is taken from the constitution. The constitution already has agencies with their mandate to protect the sovereignty of Nigeria. There are people whose job is to do countermeasure. Let me use that word. Now, as to the issue of having people being trained in terms of specific availability of human capacity for health security, yes. Trainings are not just in broad terms. There are people that have been trained. I did mention it in passing that we have had people trained and people who are leading researchers that we have not categorized as critical national asset. I'm sure, Dr. Geoffrey, you don't want me to give you their names and their phone numbers because they've become critical national asset. So there are people who are trained. There are people who are being empowered. We have a database which we share with partners on need-to-know basis. The Nigerian Security and Civil Defense have a very viable counter-bioterrorism desk. People are being trained. In terms of, when we say all hazard, the national security strategy didn't just envisage only biological. We also look at chemical, because eventually every crisis leads to a health crisis. Every form of emergency, like the wildfire we just witnessed in the US, in Australia, in Canada, eventually, whether frostbite or heat wave, everything comes down to mortality and morbidity. So knowing that important, that is why the NSA works in collaboration with NCDC. NCDC have their mandate. The coordinating role of the NSA is not to usurp other people who are required by Constitution to do their work. What the NSA does is to see that coordination is going on and that people who are heading those agencies are doing their work. I did mention in my presentation that we have biosafety and biosecurity as one of the 19 thematic areas. That will fall under National Biotech Development Agency and National Biosecurity and Biosafety Management Agency. Those will be there. Those organizations, those agencies, they function under what we call normal STP, standard temperature and pressure. When it now becomes negative, when it's not a deliberate event, Constitution does not give them the power. It becomes an armed forces, it becomes a counter-terrorism operations, which fall under the Office of National Security Advisor through the National Counter-Terrorism Center. We now walk through agencies like the DSS, the NIA. Then as to the issue of information down to subnational level, I'm telling you right now, reports are generated by our men in the field every day. And we'll be able to synergize that they work with information officers in the local government so that when I get report, that's my desk, as the head of medical intelligence, when they get report, they also share it with the DSNO, as disease surveillance officers at the district, at the subnational level, which, of course, data is bottom up, decision is top down. So that instrument exists, that information exists. Like I said, there are some things that we don't need to have it written black and white or be signed. They are their constitutional, that's why they are being paid salaries. That is their constitutional mandate. For example, an information or a research officer who is in local government that sees something is mandated by training and duty to report it. And as we report, they report both vertically and horizontally. Horizontally, they share with the DCNO, with the DSNO, who is the civilian component of disease surveillance. And then they also report it vertically because of the command and control. Because it would be embarrassing, for example, for an official of a security agency to report a disease to the state and the DG at the national level has not gotten it. So so there's that leeway of interaction. There's that leeway for us to go back and forth. Like disease response is not cast in stone. There's a measure of fluidity, there's a measure of flexibility, but what matters is that the relevant data are captured. The relevant information is relayed. So in that regard, we can say we have availability of human capacity. All hazards are being reported. The last time there was a crisis, there was something that looks like anthrax in Niger, it was reported. The last time there was white polio virus in Zinda area of Niger, it was reported, transnational. So in that regard, we work. Then as per the nature of Interpol, we have the Nigerian Police Force, is the national Interpol point of contact. We work together. The last time there was a theft of something that looked like uranium, it was reported. It was tracked. Investigations are still ongoing. So that instrument exists. It will be out of context to start putting PowerPoint of those that made the arrest, where it's being investigated. No, because why is CBRNEA, why do we consider introducing CBRNEA element in our simulation exercises? Because much of radiological equipment are used in the oil industry, in the mines industry, in the research industry. So the training has been on for the past 5 years on how to detect and because if you don't detect, you cannot respond. Part of epidemiological intelligence. If you don't detect, you can't respond. You only respond to what you see. So those trainings have gone on, and they have been sustained at a very higher national level. Then the other point you mentioned, first responder, yes. Then the National Crisis Management Doctrine, that document, the final version signed by President was on the 26th version of revised version. It's like a multi-plug. It details, not in pedestal elemental form, it details which agency lead in a particular crisis. For example, if it's flood we are dealing with, you don't expect NCDC to lead in flood response. NCDC will take the backstage waiting for human casualty. NEMA will move in. The Federal Fire Service will move in. But if we are dealing with Ebola or those things, of course, you don't expect a Minister of Transport to be the front line of covering people when NCDC has not done their work. So that document spells out who take lead per time. It's like issue of Bruce commander. He's the commander. When you get there, you take charge. But when the person mandated by constitution, by their mandate comes in, you take a back seat. All being coordinated. I'll give you an instance. During the COVID-19, the NSA activated Joint Operations Room in PC4. PC4 is Presidential Crisis Command and Control Communication Center. Is villa. It's inside the villa itself. Now, when COVID-19 was going on, while the PTF civilian elements were meeting in SGF, as Secretary of Government Federation Office, where they were meeting every day, all the optics, all the TV going on, nobody was seeing the JOR in our meeting in the villa because there's the optic part and there's the silent part. That is the fusion that the security have with public health authorities. And that has worked very seamlessly. Thank you.
I have to say you've done a good job from a security perspective. I'd like to move this forward and have comments first from our technical experts. No comments? The plenary? Yes, there's one hand over there. Please, could you give her a microphone?
Okay, thank you very much, moderator. Okay. I just want to give an addition to what the presenter has said in terms of training to enhance global health security. In Nigeria, we have a very good achievement in the area of training to enhance global health security and linking it with the military support. During the AVOC stage training, we were able to train together as first-line responders for surge from the Federal Ministry of Defense, Nigerian Police, Nigerian Air Force, and the Federal Road Safety Corps, and some military personnel from the Nigerian Emergency Management Agency. And this also forms the workforce for Nigeria for surge in response to health emergencies. Thank you.
Thank you. I'd like us to zoom in on the priority action slide. I knew this was not going to be easy. It's not unique to Nigeria. The security people have their own language, including sometimes the things we say mean totally different in their context. So I appreciate you and thank you so much. On this particular slide, I would like to ask if your team is contented with these 6 priority areas, if you believe strongly so that these priority areas will move Nigeria forward in terms of compliance for this technical area.
We do. We believe if these are well captured and attended to, it will move us higher. We are looking at sustainability, actually. It's not as if some things are not happening in silos or piecemeal, but we know that piecemeal approach doesn't snowball into big fire. We want it sustained. We want it to be something that if you wake any officer up in Zungeru or in Abia, the person wakes up to know what to do. That's why we are looking at standardized validation, so that it's not subject to personality. We're trying to make it institutional. Because if it's institutional, whether I'm there or not, the training will go on. Whether I'm this party or not, so we hope it will work.
Thank you. We can go to the slide with the score. So you've scored yourself a 3, and it says MOU or other agreements protocol that includes at least roles, responsibilities, SOPs, and information to be shared exists between public health and authorities within the country and has been formally accepted to address all hazards. At this point in time, I'm taking your word, but subject to verification with the body of evidence that you will produce for us on site, because I understand the context of the security nature of some of these engagements. It's not for all the eyes. So I would wish to propose the 3 subject to you satisfying the body of evidence that we will see on Thursday. And then we will come back and inform the plenary whether that score stands or not. Catherine.
Thank you very much for the presentation. Maybe my concern on your presentation would be on where you're talking about on your priority actions. You talked about developing a plan for exercises. I'm proposing probably that you do the development and you also conduct the plan. Again, and you also mentioned participation in points of entry. In points of entry, they have got that capacity to do a simulation exercise that is all hazard. Probably you can also be part of it, and then you do it once to save costs. The other thing that I wanted to confirm is do you have have reports that you share between public and the security authorities? I understand we are talking about civilians and non-civilians. So is there, do you have any reports that you share with the other counterpart? And if you do have them, what type of reports are they, and can we have access to actually see those reports? Thank you.
Are you done? Okay. Yeah, okay. Thank you for your observation. We will work on that to see the curriculum developed before the annual plan. And what we're actually looking at the annual plan is that we are trying to see that the plan is not subject to political variation. Because last year, we were actually peeping into level 4. It's just that last year, simulation couldn't hold because political tension. So we are hoping to have a structure that will be isolated from, so that we can do that. Then the issue of information sharing, there's information sharing. What is there is that, in national security, panic management is part of national security, because if you don't manage panic very well, or perception management, you can even have another crisis out of poor perception. So the information we share is that which the government feel is important and important for the responders to act on. However, there's a back channel information sharing with the respective CEOs and the DGs on need-to-know basis. I'm privy to that, and that is going on. Thank you.
Thank you. I'd like to ask my colleagues, the technical experts, if you agree with the scoring before I make a final comment on the priority actions. Do you all agree? Okay. So, on the priority actions, like we said, this tool is not cast on stone. As we are going to work and look at the priority actions, and as you build capacity on DEs or CBRN and E, please consider cyber security issues. Add it onto your basket, because that probably, maybe not now, but in the very near future, is going to be as big as any other public health event of biological or chemical nature. That would be my parting shot for you. Otherwise, thank you, and thank you your team. Thanks to your team for the good job that you have done.
Thank you so much. Thank you, and we reach consensus on this technical area, and we move forward to the next technical area. I thank you, and you will have contact on concluding on the priority actions. Thank you.
Thank you very much. Thank you.
Linking public health with security team as they go back to their various seats. Thank you. Okay. Well done. Thank you very much. We'll be taking... Okay. Yeah, they've reminded me that we need to do, as we actually ask the next team to come up, risk communication, we'll need an icebreaker. So let me think about something. While we ask the external team and the team for risk communication, Dr. Yahaya, Simon Idoko from NOA, Solomon Bawa from Ministry of Agric, Omolara Oyinlola from Breakthrough Action. Please come forward for the risk communication. So let me think about an icebreaker. So everybody stand up, please. So, first of all, I'm not going to ask you to touch your toes, because if some people go down, they can't come back up. So I won't do that. We won't do that, I promise you. So instead, what we'll do is you're going to use your head as the tip of a pen and spell your name. So is there anybody who has the longest name here? Okay, so well, we'll just spell it simple. We'll spell Nigeria. So, N. Okay, let's start. Let's everybody get some space. Get some space. Stretch your hand. Left hand, left leg, right leg. And then you need to use your head now as your ballpoint pen to spell Nigeria. So the person whose head comes the lowest will get a present from me. Okay. So N. No, some people are using O. No, that's not O. That's not N. N. And in capital. Okay. Then I. Capital I. Capital I. Capital I. Some people need to collect change from their primary school, it seems. Capital I, okay. G, capital G. Capital E. Capital R. R. R for radio. What's the next one? Capital I. And then capital A. And then should we spell Tinubu too? No, let's not that. Okay. Okay, all right, thanks. So we also want you to do this. Yeah, how many of you are on Twitter? Or X? It's X now, isn't it? Okay. Twitter. So we want you to take a selfie. Go on Twitter, and then go on X. Okay, take a picture. Go on X or Twitter or Threads, whichever one. And then you post hashtag JE Nigeria 2023 and tag at ncdc.gov. Yeah, is that clear? I'm sure a few people are confused about what that means. We forgive you, but if you know what to do, then do, or you ask someone to help you do that. So we'd like to invite Dr. Disu and the risk communication team. Okay.
Before you introduce the next team, there was reached agreement by another team. So if you permit, I would like to ask the team lead, the Nigerian team lead of P5, zoonotic disease, and the team lead of the external team, Mr. What was your name? Okay, Mr. O. So you reach consensus. Yes. Let us know.
Good afternoon, all. We had a little. It wasn't a disagreement, but we've politely reached consensus on our scores. We've convinced Richard beyond reasonable doubt that we are on possibly 3.5. So for P5.1, surveillance of zoonotic diseases, it was initially proposed for 2, but we maintained 3. For response to zoonotic diseases, we still have a 3. And for sanitary animal production practices, we proposed a 2, but we've agreed to step down to 1.
For the first variable, the terminology was coordinated surveillance, I think. And we were not so sure because they were saying yes, but they pelted me with lots of evidence to suggest that it is effectively coordinated. So, of course, it became a 3.
Thank you very much.
And I suppose you also agreed on priority actions? Okay, so we can conclude this chapter, meaning that we already had 10 technical areas where we reached consensus. This is number 11. We have a total of 19, so we have 8 to go. And I would really like to applaud all of you for having reached consensus for more than half of all the technical areas. So now, Mr. Moderator, I do not see the moderator. I will be the moderator. I give the floor to you.
No, they have the mic.
Floor is to you.
Thank you. Good afternoon, DG in absentia, and all other protocols duly observed. Dr. Agugo, thank you for that icebreaker. The motto for U.S. Center for Disease Control is right message at the right time can save life. But our own motto in Nigeria for risk communication is right message with right action can save life. And the action is what Dr. Agugo has done, because it's risky to sit down for too long a time. Thank you very much. And so I will be taking us on the technical area for risk communication. And I want to also greet our evaluators for the wonderful job they've been doing since yesterday. So we have 3 indicators as against the first evaluation we did in 2017. We had 5 indicators, which has been compressed now to 3 indicators. So it's, we're unable to compare, but I believe we have made some progress. These are the abbreviations. And then for background, RCC implementation uses social science notes, community participation, two-way communication, and that leads to supporting communities in preventing and responding to public health emergencies and mitigating their impacts. The RCC capacity has developed over time through multisectoral collaboration at the national level, and is being cascaded to subnational now. We have flexible RCC systems that aligns mechanisms, models, and management of resources for meeting the predetermined and emerging needs in any outbreak. And we have adopted One Health approach for implementation of RCC in Nigeria. We also have multiple partner support for provision of digital monitoring and scanning tools, development of the nascent Nigerian infodemic management system, which leverages our existing event-based surveillance system to guide risk communication approaches. And we have also been using social science methods, such as human-centered design, to facilitate bottom-up approach interventions and community ownership. The Global Health Security Index score in 2021 increased from 50 to 83% for Nigeria, with Nigeria ranking 15 out of 195 countries. By that ranking, Nigeria has the most improved score from 2019 to 2021. The first indicator is RCC system for emergencies. We ranked ourselves 4 here, and these are the rationale for that. Availability of strategic documents, multi-hazard risk communication plan, guideline, infodemic management guidelines, social media strategy, SOPs, and other documents alike that have guided RCC implementation before, during, and after public health emergencies. Existence of National Risk Communication Technical Working Group that is multisectoral and uses One Health approach, as well as disease-specific TWGs for coordination of RCC functions and information sharing within the EOC. We have RCC structures with dedicated TOR, has been established with trained RCC personnel across relevant MDAs for routine and surge operations. We have findings from the evaluation of real emergencies, that is after action review, and intra-action review such as COVID-19 pandemic, cholera, and Lassa fever outbreak response have been used for continuous improvement of RCC interventions. We have recently conducted RCC capacity needs assessment at the subnational level, and gaps identified are being addressed through ongoing training across different states, all the 36 states of the Federation. The strengths include availability of strategic documents to guide RCC implementation, improved regular One Health coordination among relevant stakeholders, continuous RCC capacity strengthening at national and subnational levels for such capacity, and a pool of skilled manpower for offline and online listening. And the best practices include development and use of a rapid assessment toolkit, which ensures that response activities are context-specific. We have existence of One Health RCC knowledge management platform across the One Health MDAs. Areas that need strengthening include stronger collaboration among sectors and all technical areas at subnational levels, increasing the pool of trained RCC personnel and volunteers at subnational level, and optimizing financial resources to fund RCC intervention at subnational level. We've stopped talking about lack of resources. We know we have a lot of resources, but how do we optimize them? What are the barriers that prevent us from accessing these resources? Challenges include weak multisectoral coordination structure because of at subnational level, One Health approach is here to be fully adopted. Then poor ownership of health security at the subnational level, lack of dedicated budget line for RCCE. We also have multiple policies and strategies that ensure adoption and adaptation at subnational level. Different agencies sending documents down. So this has led to overburdening staff at the subnational level. For the R5.2 indicators, which is risk communication, we called ourselves 3, and then the rationale for this are as follows. Risk communication plans, functions, and activities are embedded in the country's emergency preparedness and response plan. Development of One Health RCC training package on One Health coordination, transparent, timely, regular communication with target audiences. Availability of pool of trained spokespersons. Before COVID-19, we trained about 24 spokespersons in NCDC. In 2022, we trained another 24 spokespersons. There's functional infodemic management system that conducts regular insight analysis that guides public health messaging and interventions. We have analysis of target audiences based on trusted, preferred channels through online and offline community listening to inform design of communication interventions. The areas, the strengths include good relationship with media stakeholders, trained spokesperson for proactive engagement of the media, as well as deployment of RCC personnel during public health emergencies. We have a functional website that serves as a useful resource for public partners and media stakeholders. We have a pool of trained stakeholders on One Health risk communication at subnational level, and also capacity to use digital media for social listening and public health communication at national and subnational level, at least in 14 states, have been done. Now we have risk. The best practices include risk communication is data-driven, and adaptive interventions are developed based on feedback from the target audience and after-action reviews. Adaptation of messages to local languages and effective utilization of multi-channel approach for public health emergencies. Addressing gaps in science communication through the media EIS fellowship that we have recently launched. EIS stands for Epidemiology, Infodemiology, and Social and Behavior Change Communication. The areas that need strengthening in this indicator include improved monitoring and use of offline systems for feedback and insights to improve risk communication strategies and shape messages. Scale up infodemic management at subnational level. And then we also have the best practices. The challenges include suboptimal use of resources, and then both financial and human. Increasing attrition of health workforce that is affecting every sector in the country. Inadequate trained media spokesperson from other One Health MDAs is a challenge. And more importantly, is even delay in getting approval for spokesperson from other NDAs to respond during public health emergencies. And the last indicator is community engagement, and we score 3 here. Even though we felt we should be in 4, we met the criteria for that. We are being conservative to remain in 3, so that we need to strengthen that more. The rationale for that include availability of RCC structure at the state, LGA, and community level that are actively involved in emergency response and co-designing of emergency response initiatives. Community stakeholders such as community and traditional leaders, faith-based organizations, and civil societies have been mapped and are continuously engaged. Establishment of online and online feedback mechanism. Of course, I mentioned earlier our event-based surveillance system. We have National Orientation Agency Special and Pulse of the Nation report, and the use of behavioral science approaches such as human-centered design, knowledge, attitude, and practices survey, and etc., to inform emergency response. And collaboration among different agencies and partners, NOA, Red Cross, etc., that coordinate community engagement at national and subnational levels. The strengths include good collaboration among community-based organizations at the grassroots level, existence of active structures, including social mobilization committee, ward and community development committees, polio control structures in the community, availability of tools for conducting rapid RCC assessment before and during outbreaks. The best practices include co-creation of communication intervention and messages with affected populations, including the vulnerable populations. We did this a lot during COVID-19. Existence of a community polling dashboard, leveraging existing community structures for social listening, message development, and dissemination. Engagement of trusted voices in the community for community engagement, building capacity of community members to identify signs and symptoms, ultimately promotes early reporting. So, we need to scale up participatory approach and behavioral science across the country, improve capacity of surge mechanism for community engagement, and scale up collection analysis of community feedback and social behavioral data to additional states. Challenges include coordination gaps still remain at the subnational level, and we have geographical hard-to-reach communities and insecurity. On our multi-hazard plan, we collaborate with ONSA, Office of National Security Advisor, that coordinate the security sector to ensure we're able to access difficult-to-reach areas during conflict. Limited human resources at the subnational level, and especially in the community. Not really limited, I think it's suboptimal utilization of those resources. And then, of course, poor state LGA ownership, and that's why we are focusing on bottom-up community engagement and using human-centered design. When we empower the community, they will be able to do advocacy to the authorities, especially during election, to give them what they want. So what are our priority actions? To advocate for creation of a budget line for RCC and health promotion, as well as the institutionalization of RCC across relevant MDAs and at subnational levels. We have started this at national level already. Scale up the use of participatory approaches, social behavioral science, and feedback mechanism, both online and offline, for evidence-based RCC intervention and strategies. Strengthen ownership and framework for One Health coordination, implementation, monitoring, and evaluation of RCC at all levels. In particular, we need to also promote accountability at all levels, including the community. Scale up infodemic management at subnational level to additional states, and sustain capacity building for message co-creation and RCC competencies at all levels. These are linked to some of the documents that we have provided, and then these are partners. We have a wide range of partners and working with us, and also there's MDAs and partners. Thank you very much.
Thank you very much, Dr. IHR Disu, for the great presentation. I need to step in for Dr. Agogo, who has just stepped out.
Yes.
You have the floor, please.
Thank you so much, Dr. Besu, for this presentation. And I want to thank the RCCE team here in Nigeria. We know RCCE is a critical area of work, and looking at the complexity of Nigeria with over 200 million population, you have done a great work. Thank you very much. I'd like to begin with a few observations before we move on. I've observed, and not only with RCCE, but from other presentations, that we have more capacity at the national level, and the sub-national level, we still see some gaps or weaknesses in terms of functions and capacities there. And talking about multi-sectoral coordination has been, we know that that has not been fully functional, which is very critical to the work that we do. And it came out in your presentation as a challenge. I've observed that the health component is more stronger, and we can give reasons for that. So I'm just wondering, looking at the weakness in this area, you've talked about delay in spokesperson with all the gaps identified. Can we say that we are really stronger in that area of work in terms of our CCE?
Your question, the last one, can we say we are stronger in?
Yes, so I was talking about multi-sectoral.
The last thing you said, I understood the first part.
Yes, so how will we position our CCE?
Okay, truthfully, we have data to suggest this. I remember in 2021 when Presidential Task Force did evaluation of their response. I think RCC is called the highest point among the pillars. And then we have also seen remarkable progress in the role RCC plays compared to what we have been doing in the past, because we are better coordinated. Even though when we have pandemic that involve almost every sector in 2020, we're able to come up with an approach, we call it sector approach to stakeholders engagement, which uses 4-pronged. And that really helps us to streamline, coordinate various interests of stakeholders in ensuring that we have consistent messaging, as well as and then building trust among the public. However, we still have challenges. That is issue of bottom-up approaches, which is what we're now revisiting or considering with the introduction of human-centered design to make sure that we empower the communities. So we have started that in some states. As soon as we get more resources, we're able to scale up to other states.
Okay, thank you very much. So then we go to your challenges that you've listed.
Okay.
So looking through all the challenges that you've listed, which are critical, however, I do not see some of those challenges being elevated as areas of priority for RCCE. For example, you talked about multiple policies and strategies that require adaptation or to be adopted at the sub-national level. I didn't see that coming out clearly in the priority areas on getting that done. I'm sorry. We go to your priority areas, please. Yeah. So I didn't see that coming out here. And then you've mentioned strengthening the One Health coordination at the sub-national level. I do not see it strongly on the how. You have it there, but how are we going to do it? In terms of funds for RCCE, it's also a challenge, even though you said you have, but I know the issue of fund is a challenge all over. I didn't see that part coming out in the priority areas, the how part of how we're going to do it for RCCE. So if I may recommend, maybe on the proposed actions for RCCE, if will be accepted, can we maybe establish a multi-sectoral coordinating structure with clear term of reference at the sub-national level? Can we consider that as one of our priority areas here?
Well, because of space, and all this you said, we really appreciate them, but they are embedded in the third bullet point, strengthening ownership and framework for One Health coordination, implementation, monitoring and evaluation of RCC at all levels. And in our multi-hazard guideline, which we have also shared, these terms of reference are clearly stated from national down to sub-national level. And it's just that it's not clearly stated there, but the role that each person will play have also been stipulated in those guidelines. Then for funding, first thing we need to first do is advocate for creation of budget line for RCCE. That's to get the commitment of government. When you are bringing in stakeholders, government alone definitely cannot fund this. We need community, we need partners, we need private sectors. But government needs to show leadership, some commitment, that they are really serious about this business, because they are accountable for the health of the people, security, peace, and you cannot separate that from communicating with the people. Okay,
thank you. So may I suggest that after here, I'm looking at the priority areas. I'm looking at the challenges we have and areas that we need to improve, trying to align with the priority areas that we have. Maybe we could move on a lunchtime to look at them and see how we align them to the priority areas. So before we move on to the scoring, I would want to ask my colleague or anybody from the audience if they have any addition before we go on to the scoring.
Thank you for a very detailed presentation. I've just one, it's not a question, so it's just a comment for you to consider. Given RCC is a cross-cutting area, I mean, it runs through many different areas of public health emergencies and other areas. So my question is, I think we need to think in a many broader perspective, like, for example, when the RCC, the health emergencies or any other emergencies happen, so the many different stakeholders have got their own RCC focal points. So from our health emergency perspective, the coordination and the collaboration mechanism, what are the institutional arrangement that you consider important, and is there any oversight or regular monitoring and evaluation system in place? And do you need, this should be included as a priority action? Thank you.
Okay. Okay, so let me start with the first question. Our multi-hazard technical working group guideline has stipulated the role of different agencies. Section 4 is about coordination mechanism. It states that the lead agency will have to take responsibility for the response, but they have to share information with other stakeholders, while RCCE, as a group, technical working group, will now be able to coordinate to ensure that there is alignment of all efforts and initiatives. For instance, current anthrax outbreak in Nigeria, the burden is more on animal sector. We have a centralized emergency operations center activated, which is being led by Federal Ministry of Agriculture and Rural Development, and they have RCCE pillar that is led by someone from Federal Ministry of Agri, who is also a member of the TWG. But overall coordination is still the lead for the National Risk Commission Technical Working Group, because to ensure that when there is need to activate other sectors, other components, and when they need to come on board. And so we're working together. And if it is just like Dr. Damisa, the linking public health to security said earlier, when we have outbreaks in conflict-prone areas, we collaborate with the security agencies. It's either they provide protection for us to get there, or if it is inaccessible, their capacity is built for them to link up with the community and do community engagement, because they are an integral part of the coordination. The same thing if it's disaster-prone area. Our National Emergency Management Agency take the lead. So that is what we do. But what happens is, whichever agency is taking the lead, they share information across board for us to respond. Some of my colleagues here may want to also add to this.
I think, Dr. You have already said what I wanted to say. There's a central coordination, which is the National Risk Communication Technical Working Group, comprising of so many MDAs, about 40 of them, and each has its specific mandate to respond in terms of any outbreak. And all these functions are streamlined under the National Risk Communication Technical Working Group. So there's a coordination of activities so that MDAs do not work at cross purposes. So in terms of that, there's no any real significant threat or weakness in that area. And in terms of what the lady was saying before, we are proposing advocacy with the Nigerian Governors Forum. In fact, the advocacy session is already ongoing, but we are also continuing to engage with them for ownership and full participation and funding of risk communication activities, especially at the subnational level. Because if our governors, who are the chief executive officers at the state level, if they do not own and support risk communication activities, sometimes there are always gaps. And so that is what we are doing. It's a continuous, risk communication activities is a continuous engagement process. It's not something you do once for all. So all these are already in the strategic document we have, which is the multi-hazard risk communication technical guideline, which has been operational and is being reviewed from time to time. Perhaps it's only in optimizing or strengthening some of the weak areas that were already identified, and that is already something that must be ongoing. Thank you.
Okay, thank you very much.
Yeah, if you want to say something before.
Yeah, and just to add to the issue around coordination at the subnational level, you talked about how we intend to strengthen that, but that's currently ongoing. At the moment, we are conducting a One Health risk communication for PCDs across the 36 states. So that's an opportunity to engage RCC focal persons across the different MDAs at the subnational level. Thank you.
Okay, just to quickly add to that, we just recently conducted risk communication needs assessment across the nation to understand area of weaknesses and even strengths for us to know what to leverage and what to address. So coordination is also one of those things that are coming out, and we're already addressing them. With regards to feedback, in our multi-hazard guideline, we have four-pronged approach to stakeholder engagement. Before COVID-19 pandemic, we didn't have this, but during COVID-19 pandemic, almost everybody is a stakeholder to respond. Everybody was just writing CDC, what can they do, what can they do? So we now use sectors, different MDEs. Like for instance, I'll give example, education. So Ministry of Education was leading the educational sector, stakeholders, and in terms of safe school reopening. So they are having meetings. So the first prong of the guideline was development of sector-wide guideline. And the National Risk Communication Group supported them in developing the guideline. And the Education in Emergency Working Group was also part of that, led by UNICEF and Save the Children, as well as the Federal Ministry of Education. So now the second prong is providing technical support for them in implementing the guideline. We did all that with Ministry of Education. The third is to continuously provide updates. As science evolved of COVID-19, we continue to provide updates so that they can adjust their guideline, mainstreaming it into their policies and then systems to ensure that they are able to comply. And then the last is feedback mechanism. So we're also collecting, we design the system to collect feedback. One thing is for us to know how well they are doing with this guideline. And the second thing is to further modify or review our national guideline. And we also provide feedback at EOC to other pillars through days that we are working. So that way we're able to achieve this. And one important thing is we're able to transfer that to other ministries, youth and sport. Nigeria was able to host in 2021 the National Sport Festival that assembled about 14,000 participants across the federation, using what we got from the education. The same thing for our National Youth Service for the camp to reopen. It's the same template that was adopted. So it has worked and it has become part of what we do. When we review our guideline, we now included it in it. Thank you.
Okay, so with all the explanation, having said this, for ARA 5.1, risk communication systems for emergency, can we say we are at full confidently?
Yes.
Acknowledging the weaknesses at subnational level and all the other areas that we need to strengthen, are we still at full?
Yes, because if you look at the tool, 4 focuses on national level strength. It is at 5 you will now start seeing all these across levels. And that's why we can say we are at 4. If you look at it very well, and the tool refers to national level operation.
So we have adequate funds and everything at national level.
Well, what we said is what is adequate. You can't say this is what is adequate. It depends on how you are able to see the opportunities and convert them. We even have issues with that stating adequate fund because it's a relative thing. How can we unlock the opportunities we have? Even government, they have money, but they prioritize for other things. Okay. Once we identify that, then we're able to make sure that they continue to invest in RCCE.
Thank you very much. For the next call for 5.2 on risk communication, yes, I have gone through and I'm in agreement. I don't know from my colleagues. External evaluators.
I've got a comment on. Are we now on 5.2?
Yeah.
Because my comment was on 5.1.
Okay, we go back to 5.1.
Okay. So you mentioned in your challenges that you are having like overburdened focal persons with conflicting priorities at subnational level. And you also mentioned on your strengthening and areas that need strengthening that you need to increase the pool of RCC skilled or trained personnel and volunteers at subnational. So I don't know if you can clarify to this house, considering that you have got those 2 challenges and strength to actually do. And then how you pass that second sentence where it's saying RCC has an adequate number of skilled. Can you explain what you have said and what that second sentence is referring to?
I didn't hear you clearly, but some of the things I heard was we have challenges at subnational level. How can we be in 4? We want to strengthen. Is that what you're saying?
No, she's saying that from the challenges identified, you did mention that there is inadequate, can I read that out? Where you talk about having overburdened focal persons with conflicting priorities at the subnational level. That if the workforce at the subnational level is in such situation, how well can we now conveniently answer the question of, if you go back to the indicator now,
well,
can we go back to the indicator?
Like I said earlier, if you look at this indicator, it speaks to the strength of the national level. And why we highlight that is because we're also planning to move forward to the next level as we sustain the strength that we have at the national level. So if you look at it very well, maybe they need to review the indicator. And I think, but for what we have here, we have met this condition. So that is what we are saying. However, there are plans working with Federal Ministry of Health to develop a minimum workforce package for health promotion in the facility. In a situation whereby they will have focal person for each of these specialized areas, like maybe immunization, outbreak response, that's health security, or HIV control, and so on, so that they will all be reporting to the health promotion officer that leads. And then the other alternative is, while we are waiting for Ministry of Health, is for the DG and CDC to engage with the state commissioners for health, for them to dedicate someone for health security, who will also be reporting to the state health promotion officer.
All right, thank you for the explanation. But I'm proposing that when we are looking at that core capacity and then the scores, we should tick, okay, to say where it's starting national RCC up to areas there is a full stop, we tick that you have. Then we go to the second sentence. Can we tick and move on to the third sentence? I don't see that happening. So my proposal is that second sentence we are not passing, and we are here to help each other to improve and continue improving, and at the end have a clear picture and a good report. But if we are then going to take that second sentence and then agree to your explanation, it's not, I don't know, I'm just proposing, but I don't see us have the capacity for that second sentence, making it difficult to then say, are we in that score, or we need to go back to, because it should be a whole number. If there was a 3.5, maybe it was going to work out for you, but we don't have.
We go back to the technical area lead, because now you are taking over the technical area lead. So thank you for your comment. I get back to Michelle.
Thank you. I know the area of RCCE, BISU, it generates a lot of discussions. So having gone through the presentations and from our discussions, I want to propose the following scores. So I'm going to propose and ask my colleagues if they are in agreement with me. So for the first one, R 5.1, I will propose a score of 3 instead of 4, because we have not met all the benchmarks for level 3 before moving on to level 4. For the next one, R 5.2, the score will remain at 3. Yes, from their presentations and discussions and evidence, you are at level 3. I'm in agreement with that. For R 5.3, you've selected 3. And of course, on a community engagement, I'm also in agreement with that level. Over to members of the external team, if you are in agreement with me also.
They are in agreement. So now we have to ask to the national team, are you in agreement with our proposal for the scores?
Well, maybe we need to discuss that at the sideline, because we need to show the evidences that we have. If they are satisfied, then we'll be able to agree on what it should be. Because we are, for the skilled workforce, we've already submitted, we have a pool of people, such capacity we have trained across MDA sector. And even Nigeria can even export capacity to other countries when it comes to RCCE.
Yes,
yes.
But you don't have to, it's your full right to disagree, but I have to conclude that when there's disagreement on the score or on the priority actions, I send both teams to a side meeting, and then I ask you kindly to reach consensus in a side meeting. As soon as you reach consensus, you come back to the plenary and you explain to the plenary why and how you reached consensus. For now, and this is your full right, as it is our right to disagree with your score, it is your right to disagree with our score. That's right. So for now, I have to conclude there is not yet reached agreement on the score. I feel there is more or less agreement on the list of priority actions, but you can discuss both in a side meeting, and this means that we conclude not with consensus, it will come later, I'm sure about that, but we have to applaud both teams. Thank you so much.
Thank you so very much, Dr. Henk. And a warm round of applause to the Risk Communication and Community Engagement team. I can imagine a lot of effort put into this. Thank you so very much. And again, to our external evaluators, another warm round of applause for all the jobs so far. Thank you so very much. So I've approached the bench and I've confirmed that we have done so well for today so far, and we deserve lunch. So my job is just to declare that lunch is served, and that we will be reconvening by 3:30 to take the remaining presentations for today. May I kindly appeal to us that we please ensure that we are back in the hall by 3:30 so we can finish as early as planned. The boarding pass have been shared. Sorry. I should go ahead. So the boarding pass has been shared. So kindly get to your boarding gates, whether at the garden or you are going to be in the hall here, while our external evaluators and the front seat distinguished senior colleagues and leaders will be at the restaurant, and we should be good to go. All right? Any other information? Just a minute. Okay, so we let there's a car. So during this period, kindly check your car. Black Camry MNA 416 HK. Black Camry MNA 416. Black Corolla anyway. I'm saying Corolla and Camry. I don't know whether they're the same thing. MNA 416 HK. All right, so that will be fine for now. We will be back by 3:30 to take the proceedings to the next stage. Thank you very much. Bon appetit. let's begin to round off in the next 5 minutes. So for our colleagues outside the hall, this will be a very good time to wrap up whatever we are doing so we could come back. So in 5 minutes, we will be commencing proceedings or resuming the section. just announce. Thank you very much. Welcome back from lunch. Yes. The last section will be observing ourselves and evaluating ourselves. Maybe the... All right, so we are ready at the nick of time, and the stage is set for us to take the next technical area, National Laboratory Systems. National Laboratory Systems. So please, let's have our seats. And so for this technical area, leading the engagement on behalf of the team is no other person than the director of the Lab Services herself, in person of Mrs. Olajumoke Babatunde, the director of Lab Services NCDC. A round of applause for her, please. There's a special clapping going on a particular table. We can understand. All right, so she will be ably joined. You're welcome, Director, man. She will be ably joined by Madam Celestina Obieke. I've been struggling to pronounce this name. I hope I get it right one. Is it Obieke? A round of applause for Celestina, please, as she makes her way to the high table. Next, we have Bashak John Haudu. Celestina Obieke is from the Resolve to Save Life, if I'm correct. And the other colleagues are also joining. Last but definitely not the least, we have Dr. Odiabara Kingsley. Dr. Odiabara Kingsley joins the team. And that's the Nigerian side. While I yield the floor now to the external evaluators, to introduce themselves, then we go into the business.
Good afternoon, Mr. Moderator. Good afternoon, audience. Our external team can introduce themselves.
Geoffrey Jagero from Kenya.
Hi, Sarah Amami from RTSL.
Mic there, ma. Okay, you have the mic, ma. So the floor is yours, ma, and the time starts now.
Good afternoon, everyone. I'm Olajumoke Babatunde. I lead the laboratory technical area in NCDC, and I will also give the floor to my colleagues to also introduce themselves.
Good afternoon, everybody. Celestina Obieke from Resolve to Save Lives.
Yeah, good afternoon, everyone. My name is Kingsley Odiabara, Director, Lab Services, Federal Ministry of Health.
Good afternoon, everybody. My name is Ben Shak John Audu from the National Veterinary Research Institute, VOM.
So I don't know if we have to give the floor to the... Okay, they've done that. Okay. Yes, thank you. Okay, the list of abbreviations. And so the laboratory services are provided by government, private and non-governmental agencies. And these services are also provided in a tiered healthcare delivery system that's talking about primary, secondary, and tertiary sectors. And so these services are rendered in clinical, public health, and research laboratories for laboratory-based surveillance of outbreaks of emerging and re-emerging zoonotic diseases, and as well as confirmation of infectious disease pathogens. So over the years, to strengthen the laboratory systems, policies, guidelines have been developed to provide frameworks for a coordinated and effective laboratory services. And if these policies are implemented, they would have gone a long way in improving the quality of laboratory services in Nigeria. But unfortunately, implementation is usually hindered by inadequate budgetary provisions. And so prior to 2017, that was when the last JEE was conducted, the country laboratory system had limited capacity for advanced diagnostic testing and pathogen sequencing. We only relied majorly on the traditional methods of microscopic culture and sensitivity, and then there was no mechanism in place for sample transportation and sample movements, both at national and subnational levels, were majorly unorganized and ad hoc, and a national reference laboratory was designated for epidemic-prone diseases, but with limited testing capacity. So over the past 5 years, a lot of interventions have been implemented. And then in 2023, the country now has capacity for advanced molecular testing and pathogen sequencing, and also a defined mechanism for sample transportation at the national level is already in place. And so if you look at the indicator 1.1, talking about specimen referral and transport system, we gave ourselves 2, because like I said, although the national has an organized method of sample movement, but there's still a problem with intrastate, that is at the national, subnational level. So the rationale 1, sample referral and transport is organized at the national level for all priority diseases, and the country has also developed the NISTRI policy. So this policy is, when implemented, we also support the integrated movement of samples across the 3 sectors. And so animal and environmental sectors still rely on ad hoc sample transport methods. So specimen referral also, we look at our strengths. Like I said earlier on, system is already in place for transporting of priority diseases. Many of the laboratory personnel have been trained on safe collection, packaging, and movement of biological samples, and many of them are already IHR certified. So best practice, engagement of 3PLs, like I said, unlike in the past, when the country was moving samples, using the rudimentary and unsafe methods with a lot of biosecurity and biosafety concerns. Now, we have already engaged 3PLs to move samples from the subnational to the testing labs across the country. So strengthening, we need to strengthen integration of sample referral systems in the context of One Health. And then additionally, we also need to strengthen the subnational sample management and transportation mechanisms. So the major challenge is that we have also some disease programs, like the TB, HIV programs. They also have their different mechanisms for moving samples from the local government even to the various testing labs. So most times this process is still partners driven, and this is not sustainable. So for us to be able to, for our programs to be sustainable, government needs to take ownership. So looking at the indicator 2, which is laboratory quality system, we feel we should be on level 3 because national quality is not. Do I continue?
Just a minute. It's going to come up.
Apologies for the break in transmission. All right.
So the indicator 1.2, which is the laboratory quality system. So we gave ourselves 3 because right now, national quality standards have been developed and implemented at national level. Activities include licensing of laboratories in conformity with international standards. So rationale behind the 3, number 1 is that the country has regulatory agencies, the Medical Laboratory Science Council and NINAS, that are responsible for licensing of laboratories. And then a national laboratory quality manual has also been developed, and QMS implementation is ongoing in many laboratories. 14 laboratories currently are accredited to both national and international standards. And these laboratories cut across the human and animal sectors. So strengths, regulatory agencies, MLSN, in place for accreditation of laboratories, and many of the laboratories are participating in EQA program for priority diseases. And the country also has a pool of SLAMTA trainers and mentors to support the in-country quality management system implementation and to also prepare laboratories for accreditation. So, areas which need strengthening, number 1, is capacity building, because many of our laboratory personnel still do not have the prerequisite knowledge for the implementation of quality management systems. So we need to continue to build capacity across all levels of the tiered laboratory network. There's also need for us to train more SLAMTA mentors to support QMS implementation across all the sectors. This is very important because NCDC has a mandate to lead with preparedness, detection and response to diseases of public health importance. So the only way by which we can detect accurately is when our results are reliable, reproducible, and timely. And that can only be achieved through the implementation of quality management system. So looking at laboratory testing capacity modalities, we feel we should be on 4 because right now, laboratory can perform, the country has the capacity to perform PCR testing, bacterial culture with AST, and then most laboratories also have quality assurance processes in place, and also with some basic sequencing capacity in country. So I've already highlighted this, the rationale. So areas which need testing, there's need for us to continue to expand testing capacity for the IDSR priority diseases. Right now, we have capacity to detect CSM, cholera, VHFs, and a host of other diseases across both human and animal sectors. And the good thing about it is that the capacity is already there, so there's need to continue to train and to also expand this capacity to cover other emerging and re-emerging diseases that we might come across in future. So we also have the testing capacity. Capacity is also available for points of care, especially for some like malaria, HIV, and but not really covered by cholera. We have that RDT for cholera, but we need to also expand that to cover other priority diseases. So the major challenge here is that most laboratories are not geo-mapped. Only the preferred supported laboratories are geo-mapped currently. So, and this is a big challenge because this has not actually allowed us to maximize the capacity in country. Because when our labs are geo-mapped, we'll be able to have the information at the press of a button, the human resource, the equipment platforms, and that will guide us in optimizing these labs for more pathogens, for the laboratory testing of more pathogens. But that is not yet in place. So for effective national diagnostic testing, we feel we should be on level 3 because looking at the rationale, we have developed a national tiered laboratory network document, which is still a draft and yet to be approved. And the country also has a national essential diagnostic list in line with the tiered laboratory network. This essential diagnostic list is actually to guide test selection across the three tiers of healthcare delivery system. And so implementation of tiered diagnostic strategies exist within parallel programs. So currently we have a lot of parallel programs with different networks like TB, like HIV, and the NCDC lab network. So strengths. The capacity to quickly expand laboratory network to provide adequate coverage. This was demonstrated during COVID. At the beginning of the pandemic, within the public health space, there were only 4 PCR laboratories. But within the twinkling of an eye, we were able to rapidly expand the COVID-19 lab network and currently we have over 100 laboratories. And in recognition of our capacity and capabilities in the West Africa sub-region, 4 of our laboratories in Nigeria have been designated as regional reference lab for cholera, for influenza and other respiratory diseases, and also for VHFs and animal diseases. So in recognition of the capacity in Nigeria. So for areas which need strengthening, we need to implement, although we have that system to move samples, but real-time tracking still remains a challenge. And laboratory services are fragmented along disease programs at different levels of healthcare system. So we are also looking at integration so that we can maximize the available resources in country. So looking at the priority areas for action, number 1 is to strengthen subnational sample transport mechanisms. These still remain unorganized, and ad hoc at the subnational level. So there's need to strengthen that. We also need to support laboratories to achieve and sustain accreditation according to national and international standards. Like I said earlier on, many laboratories lack that prerequisite skill to implement quality management system. And that is the only way by which our results can be reliable, reproducible, and timely. And so a critical component of implementation of QMS is enrollment for EQA program. So currently the country has a national EQA laboratory, but there's need for us to expand the EQA services to cover more priority diseases. So we also need to implement a national LIMS, because like I said, a lot of disease programs and laboratory data are in bits with all the different disease programs, so integration is very important, especially for public health decisions. So we also need to strengthen the institutionalization of the private sector laboratories in public health surveillance and reporting. This was demonstrated during the COVID pandemic, and most of the laboratory services are provided by the private sector. So it will be a good one if we can continue to collaborate with them so that they can also participate in the testing of some of our priority diseases for improved turnaround time. And a major challenge in the country is incessant stock out of reagents, stock out of consumables, stock out of materials for sample movement. So a key activity in the National Laboratory Strategic Policy is to explore in-country capacity for production of reagents and laboratory commodities, especially to increase sustainability of supply chain. So, these are the supporting documents. Thank you.
Thank you very much. Thank you very much, the National Laboratory Systems team. And to the evaluators, the floor is yours.
Thank you for your wonderful presentation. And I commend your team for the efforts that the sector has made in terms of addressing the pressing areas within this technical area or core capacity for Nigeria. I would like us to go to the slide on D11, specimen referral and transport system. I mean the area which needs strengthening. Yeah, yes. So one of the areas that you highlight here that requires strengthening is an effective real-time tracking system for sample transport. I think within the context of our language in laboratory system, you are referring to remote logging. Is that so?
Yes, so that we'll be able to track location of our samples while monitoring the temperature at the same time.
Thank you. The second and the third bullet, if the notes are okay, are good areas to look at in terms of strengthening. That basically integration. Once you talk about integration of sample referral systems in the context of One Health, then you include matters of transportation and all those. So I think bullet number 3 is not necessary. I want to move us very quickly to the slide on D1.2, laboratory quality system. Laboratory quality system, D1.2, areas which need strengthening. Great, so I realize that the presentation that we have here is different from what was shared with us. So I take note of that. Very quickly, let's move to D1.3, strengths and best practices. Yes, on best practices. Use of testing algorithms that conform to international testing best practices. If that's a best practice, does that algorithm cover all the priority pathogens for Nigeria?
Algorithms for all the priority pathogens?
Yeah.
Yes, we have not really developed for all, but we have started, and then over time we'll be able to cover all the priority pathogens for the country. So for now, we have developed for cholera, for CSM, and we are developing for the diphtheria.
So you have about 3 algorithms.
Algorithms, yes.
Against how many pathogens?
Against what?
Against how many pathogens, priority pathogens?
Like 3, yes.
No, how many pathogens, how many priority pathogens do you have for Nigeria? Because it's different from country to country.
So for NCDC, we have developed for CSM, we have developed for cholera, we are also developing for...
okay, let me clarify.
Not SOPs.
Let me
are you
clarify.
referring to SOPs?
I know. Let me clarify.
Okay.
I think one of the presentations yesterday by one of the team members from Nigeria had mentioned that Nigeria has over 40 endemic diseases, and I think probably up to 10 or 20. So I just want to put a number. What's the number of priority pathogens for Nigeria? Anyone can help from this, because this is important. Are they 10? Are they 15?
Infectious.
So as we debate about that, I don't want us to debate. This is my counsel. Obviously, that number is not 5. It's not even 10. I don't have it off it.
42.
42,
yes.
So you realize that 3 algorithms against 42 is a drop in the ocean.
No, we are looking at, infectious.
Yes.
Yes, the infectious priority pathogens.
Yes.
So,
how many have you? I think I need to put some clarification here. Here in this country, we have several disease programs that are supported by different partners. And there are also programs that are actually implemented at the 3 levels of care. Yes, though in the IDSRO we have about 41 or 42 pathogens listed that are common in Nigeria. Of course, there are, again, filtration among these to be able to determine the very priority ones. For instance, what the Director of Public Health Lab has stated here did not include that of TB. And of course, you all know that that is also a priority disease, particularly in Nigeria and sub-Saharan Africa. And there are others. So I think that it's not just 3 against 42.
Thank you. So this is where I'm coming from. If you have already 3, if you have algorithms targeting 3 disease pathogens against the many that you have, then my counsel would be this should not be a best practice. It should actually be an area that needs to be strengthened. Because what Nigeria needs is if person X tests for disease Y in Borno State and person Z tests the same pathogen in Lagos or somewhere,
The same thing.
there should be what? You understand?
There'll be, yeah, consistency
Exactly.
and all
Exactly.
that. So as it is, like I mentioned, we talk about the TB, they have the national algorithm, there's the HIV, there's national algorithm, there's even the malaria, there's national algorithm.
So let's
there's the
get this
viral
straight.
hepatitis,
Okay.
yeah, national. So it's important that I make this clarification here that they all have their nationally approved testing algorithm.
Yes, and my counsel is we need to move that forward beyond what we normally know. These vertical disease programs, HIV, TB, malaria, that's easy to do. So you should make a concerted effort to expand this algorithm beyond those normal disease vertical programs that we know about.
Okay,
Let's move
noted.
on.
It's noted.
Let's move on to areas which need strengthening. I don't know whether the second slide on that. On D1.4 on strengths and best practices.
This thing is
D1.4. Yes. Collaboration between the parallel disease programs, private sector and public health laboratories for laboratory testing during the COVID-19 pandemic. Well, that was a best practice. What is the best practice now? Is this collaboration still happening? Do you have evidence?
yes, the collaboration is still happening.
Yeah, I want to answer this question and clarify to the team and to everyone here what is currently happening. Of course, it must be noted that before the COVID-19 pandemic, there were issues, and the weaknesses of the system were not very glaring. And so when the COVID-19 pandemic came, we all saw the gaps in the system, the need to strengthen the system. But one thing again it created for us is that, there was a shutdown. And so that lockdown gave us the reason to learn one important lesson, and that is integration of our diagnostic services. So while we had a support to strengthen our system and build a resilient system for future pandemic response, we also saw the need to optimize resources. And how can we optimize resources? How do we optimize the human resources that are valuable? How do we optimize our supply chain system? How do you optimize our waste management system? And so the idea of diagnostic integration came in, and that is being coordinated by the Ministry of Health. A lot of engagement is ongoing, and we are very hopeful that, yes, in a very short time, we'll be able to develop a national protocol for integration of all our services. Engagement is going on. We'll be speaking with the disease program, and we have been assured of the support of both the Global Fund implementing team, the UFG implementing team, and there's a political will and support coming from the Ministry of Health. The NCDC is right at the center of it with the ministry, and that's why I can assure you that, yes, this was before the pandemic, but the pandemic opened up the door, and the reason for us to learn the vital lesson. And based on that vital lesson, we are moving forward. Thank you.
So let me just say something. I think the wording there should have been maybe the collaboration right from the time of COVID-19 pandemic has been sustained to the present time.
Yeah, I was just going to say that and then probably add a little bit to say, even before the COVID pandemic, we have private sector labs that are involved in public health surveillance. For instance, in the TB network, there are private labs. As part of our sequencing network as well, there are private labs that are involved in those systems, research labs that also work along the public health surveillance system. So prior to COVID, there was some integration of services, some working together. COVID made it stronger, and that is being sustained even post-COVID. It might not be, the demand for those testing services might not be as high as it was during the COVID pandemic, but those resources are still there and available, and they are deployed whenever they are needed within the parallel programs and across the sectors as well.
I want to take you back to that very bullet. And the question I want to ask is, building on the experience of COVID-19, has the country made any efforts towards integrating diagnostics using multi-disease platforms? Because we know, for instance, that there are many tools we have around within our laboratory systems. And it's only COVID that taught us that equipment X should not be limited to testing disease Y. It can be used to test many other agents. So what efforts have you made on that aspect? That's question number one. Number two, and I wish that you give me attention. Number two, from COVID, again, there is need for what you call integrating diagnostic. We call it DNO, Diagnostic Network Optimization. Have you, as a country, developed that tool, or are you in the process of developing that tool? Why is it important? Because both for diagnostics, patient care, and disease surveillance, you don't have to move a sample from facility X to Y 500 kilometers away when there is a facility 30 kilometers away that can do the same job. So I want you to respond to those two questions with evidence.
Yes, for diagnostic network optimization, I think the process has started because we find it's ready to support that process. And so, yes, when you come over to the lab, we see some of the communications around that. Because we also know that this is very important because we will be able to also have access, the full information about the equipment platform. And so we don't need to move samples from, Nigeria is a large country, because the challenge we have right now is sometimes we have to move samples right from Borno State to NRL Abuja for testing. But if our laboratories, this DNO is also talking about geomapping of these labs. So if these labs are geomapped, we will have an idea of the equipment platforms, and then if there's any need for us to also strengthen that lab, for the lab to be able to carry out some of the testing for these priority diseases, that will be done. But that has already started. FIND is supporting, and also Africa CDC is also supporting this stride.
Let's move to the priority area slide. Is this priority areas? Yeah. So this strengthening of national sample transport mechanisms, that's fine. Implementation of national LIMS that accommodates all diseases and is interoperable across the three sectors. I was just wondering whether there is a legal tool that backstops this, and I'm speaking from within the context of cybersecurity. does the country have a legal mechanism that would backstop implementation of LIMS? Because it would mean with remote logging and testing from the most primary facility, with data moving through to the national level and across the sectors, do you have a legal mechanism to back that up? And question number 2, are you satisfied with these priority areas as they are?
So
very quickly.
Okay, first of all, for the LIMS, for number 3, this is being supported by Global Fund, and the process is led by the Federal Ministry of Health. So I will allow the Director of Labs, Federal Ministry of Health, who has been leading this effort, to speak to that.
All right, thank you, Director of Public Health Lab. It is true that the Ministry of Health, along with all relevant stakeholders, identified the need to develop an electronics information system, laboratory information system, that will be interoperable with all existing data collection system in all the programs, and including the clinical facilities. Currently, the NCDC has the SOMAS, we have the DHIS2 that many facilities are reporting to, and then the DHIS2 is domiciled in the Department of Health Planning, Research, and Statistics in the Federal Ministry of Health. In fact, this department has the responsibility to, as a custodian of all policy documents of the Federal Ministry of Health. And so we identified this need, and are even in line with the provision of the Nigerian Medical Laboratory Policy and Strategic Plan, which recommends that, we should develop an appropriate laboratory information tool system. So we put up this, and the Global Fund approved, and the vendor for this project is GGHN. The plan is to develop a system where we can have a real-time monitoring of data collection and management. And that tool is expected to be domiciled in the National Laboratory Services Directorate in the ministry. It will be interoperable with all existing lab information systems. It's about 90% completed, and then is to be deployed in all the, for now, the first phase is in one local government, in one ward each of the 774 local government across the country.
Thank you for your answer. May I ask you a question, and then I'm regarding to the tool itself. The tool defines the national laboratory system as a collaborative community of clinical laboratories, public health laboratories, and many individual partners who test and test results, also of the animal health. It is also saying the national laboratory system should include ability to conduct diagnostic tests for priority diseases, ability to transport specimens safely and quickly from 80% or more intermediate levels. So when I hear the discussions, and I can understand this, I think there is a misperception between what a national laboratory in the capital can do or what the system around the whole country is. And when I see in your priority actions that you are proposing yourself, then I see that the weak link is carrying the specimens over the country. How can you have a good system when you cannot carry specimens? We haven't heard a word about the animal health system. That's also part of the system. The system is as strong as its weakest link. So I'm not going to scores or anything, that's to the technical lead. It is my role as a team lead to stick to the tool. We are not talking about the highest level laboratory in the country, we are talking about the system.
Okay, can I respond to that? I quite agree with you. And as the National Director of Laboratory Services, what I can say now is that there is still work in progress and there is room for improvement. Of course, we know that the Global Fund has its mandate and it has its priority that is centered around the mandate for which it was established. And so whenever you make a request that is outside those priority areas of the Global Fund, it's not likely to be approved. And that's why we allow that, let this be done, and it's my belief to make submission to the Honorable Minister of Health to take it up to maybe the Federal Executive Council for government to ensure that, yes, this tool is expanded to cover both data coming from the animal health and the environment. Of course, that has to be borne by government or other partners that do not have restriction just to the 3 ATM disease. Thank you.
If I may add just a little bit around your specific questions around safe transport of samples. And I believe some of the technical areas may have made some comments around how the Nigeria system is structured. It's a bit complex. So what we refer to as national systems and subnational systems is really the uniqueness of our governance architecture. For health, which is for, I mean, my Nigerian counterparts probably understand what I'm saying. We have lists based on how systems are funded. The health system is on the concurrent list, which means that both the national government and the state governments at the national level have joint responsibility to fund health systems. Now, for public health investments, for instance, or case in point here, the sample transport mechanisms, at the moment it is largely structured at the national level for moving all samples from the intermediate to the testing laboratories. It doesn't really matter whether the testing laboratory is at a state capital, as long as it's the laboratory that is indicated for that test, according to the mapping. That's where the samples go. But where the major challenges usually are from the point of the sample within the states, where the samples are collected and moving them within states, to the hubs where the samples are picked up for national shipment. A lot of that still depends on national systems or ad hoc. So there's not very much funding from the state governments who are responsible for that. So when we say strengthening subnational transport mechanisms, it's more or less having systems that mirror what we have at the national level, such that all the 36 plus 1 states have similar structures to what we have at the national. So for instance, at the national, there's a National Integrated Sample Referral Network, which was referred to earlier, NISHRIN, and the NCDC also has a system for sample transportation where samples are picked up from hubs in capital states to respective testing laboratories. If we could have those kind of systems in the 37 states across the country, then we would have a properly coordinated sample transport system. But right now, where the gaps currently exist are at those subnational level at the state where it's not fully funded and a lot of the work is still ad hoc, moving samples, or it still relies heavily on national funding systems.
So just to add to what she has just said, we are also just not making efforts because we do a lot of advocacy and we've had a lot of discussions with another department within NCDC because there's need for us to take that lead to also do a lot of advocacy to policymakers at the state level and also let them see reasons why the same structure that we have at the national should also be put in place at the subnational level. So, but there are a few exceptions to this, especially I can make reference to 2 states in Nigeria, like Lagos State and I think Edo State, where we have most of the testing labs, although they are being supported at the national level, but those labs are also within the state. So the national is still responsible for the movement of samples within that state. So we are looking at, sometime in the near future, where we can have that organized system in place for sample movement because the integrity of the sample is very important. And so the quality of the results that we are churning out in our labs is also equivalent to the sample that are being received. So once the integrity is compromised and the results become questionable, so that's what we are looking at strengthening of the subnational sample transport mechanisms. Yes.
Thank you, and allow me to burst your bubble. Whenever people talk about sample transportation, networking, and referral, the people at the apex of the national laboratory system think, and wrongly so, that it's important for sample integrity to be maintained from the intermediate to the national. What's the role of a national lab? The role of a national lab is confirmation of pathogen identification. The detection is supposed to happen at the primary or the intermediate. So whenever, and I'm part of the system, so I know this is how it works. So the most important part of national sample referral and transportation should actually focus at the primary level. How a sample moves from this facility to this facility so that patient care can be managed. If you have a disease outbreak, the samples don't come to Abuja. The samples are tested at the grassroots. That's where it is important to strengthen sample referral. But we always miss it and start from the national level. I think it's important. Yes, it is important, but the sample that is coming to you and I are for confirmation using advanced technologies, PCR, sequencing, and those fancy names. So, on these priority areas, one of the things that you highlighted was that your sample referral system is donor-driven. Now, Nigeria is not unique. Once you say that, I know that sample referral in Nigeria only exists for TB, HIV, and maybe malaria. What happens to all the other disease programs?
No, so those are disease programs.
I know.
TB, malaria, HIV.
Yes. So what I'm saying, it's okay. Okay. It's okay. I'm not faulting you. What I'm saying,
I just want to explain.
What I'm saying
yes.
is priority number one is very important, but it falls short of addressing the national program. As my colleague and lead has said, the national laboratory system transcends human health. It must serve animal health and environment. So when addressing that, we'll have to rework that and see that that priority area can address the national laboratory system as a whole.
Okay, so agreed.
Okay.
So we will remove the sub and leave it as national sample transport.
Those are semantics. We can work on them later. I want to make some suggestions on your priority areas. For national sample referral network to work, I would wish to know if we have a material transfer agreement, policy, or legal framework. Material transfer agreement. You'll not just be moving biological samples or valuable biological material from X to Y without some legal backing. You can. And remember, that takes care of inter-lab, inter-institution sample movement, even for the research settings. As we say, this is national laboratory system.
So just to inform, we have the national manual and protocol for integrated sample referral, which was approved, though supported by partners and the Global Fund, and then approved by the Honorable Minister for Health. It has also been approved by the National Council on Health, which is the national, the highest organ for decision-making within the health sector. Again, for partners, I know that there are, like you rightly said, that some some level of implementation is supported by partners. So for those partners, they've also engaged third-party logistics, and they have that agreement with those third-party logistics. Currently, with the support of the Global Fund, we want to pilot the National Integrated Sample Referral in 2 states using the NIPOST. NIPOST is the Nigerian logistic company. And NACA, which is the principal recipient of the Global Fund, has signed an MOU, including, and that MOU it captures some of the content of agreement for movement of materials, biological materials. So I don't know if that MOU, that agreement signed by the DG of NACA and the Postmaster General is what you are referring to as the agreement for material transfer, but it captures some content of enabling them to move biological samples in the implementation of the industry.
We'll request to
but
see
at the
that
national
document.
level.
We'll request to see that document during the visit on Thursday. So I suggest you put it on your to-do list. It's one of the documents that you must produce on Thursday. An MTA or something that defines MTA for Nigeria for movement of valuable biological materials. We'll leave that at that. Okay, moving forward. So I wanted to suggest some additional priority actions with permission. So we said that, where is that? So we'll work on number 1. Number 2, okay. Number 3, support to NECAL for expansion of QA services for more priority diseases. It's fine and it sounds fancy, but we'll need to see how is it something that can be quantified? Number 2, EQA is not sufficient. I think your team needs to begin to think about moving into LCQI, which is more sustainable for improving quality systems within the laboratories. And then bullet number 4, I still would wish that you go back and interrogate yourselves whether you have something about data protection or whether it is a policy or a legal instrument that will backstop number 4. Then, using parentheses, this is yes. Yeah, I know. Okay, sorry. So I think we are moving to the audience. If you have any comments or questions you want to ask before we move to the technical experts.
All right. So distinguished colleagues, it's now our time to provide feedback, comments, questions, clarifications, further additions. So we have some hands up. Let's get quickly to them. Okay, you want to start with the with the lab team? Okay.
Okay. Good afternoon, all. Just to some clarification. One of the questions on collaboration between parallel disease program. Yes, we have in country prior to COVID-19, the HIV/TB malaria program already has laboratories, molecular diagnostic activities ongoing. And most of those labs were also integrated into this during the COVID pandemic. They were also used. So there are documentation on the information on those labs on the NCDC website. So that can also suffice for the question that was raised. Then the issue around the MTA. We have MTA that have been developed. For NCDC, we have MTA, and other institutions in country also have their MTAs. So we have documents that we can provide for movement of priority diseases between the the national reference lab and out to other laboratories in country, and which is already in place. So that we can provide that. And I believe other institutions has like NIMA and NBRI. I'm not too sure, but I believe they also have for them to move samples out of the country and the rest. So I'll give it to my colleague here.
Also, in addition to the EQA program of the country, we also have the National Continuous Quality Improvement Program. And this one is domiciled in the Medical Laboratory Science Council of Nigeria, and it cuts across all tiers of medical laboratories, tertiary, the secondary, and even the primary. So laboratories are scored according to their star level, whether you are in star 1 or star 2 or star 3. And those that are able to achieve star 4 are now moved to accreditation. And a lot of laboratories have been able to achieve accreditation through this process. I know you talked about, apart from EQA, which other programs do we have? And you mentioned the LCQI. We have it in country and a lot of laboratories. And we have done a lot of training through this. Also, we have also embedded mentors in a lot of laboratories in Nigeria. There was a time we had over 76 laboratories cut across the 6 geopolitical zones, and we embedded mentors in this laboratory. A lot of laboratories were able to achieve 3 stars, and some of these laboratories are now accredited to ISO 15189. So with this, and also within the national EQA program, I will have a national laboratory accredited to ISO 17043 in Sayed Zaria. And we have what we call a continuous quality improvement team. With this team, if you fail an EQA, you are able to get somebody to follow you up, go to the laboratory, find out exactly why you failed, and organize some trainings. And with that, a lot of laboratories are able to move from such failure to even passing their IQA program. So we have that embedded in the Medical Laboratory Science Council of Nigeria, and so far it's working.
Thank you. To the team, yes or no, the LCQI program that he has just described, is it only applicable within the human health sector or across the sectors?
Yes, human sector, yes. I also believe that you should have that in the animal sector, because we have 2 laboratories that have achieved international accreditation, and there's no way you can implement quality management system without continuous improvement. So, but I will allow the colleague from the animal sector to also speak to that.
Not to take too much of her time, I think she's already said about it. Here in the National Reference Laboratory in Rome, we've achieved the ISO 17025 accreditation, and that was possible because of such procedures that from one level to the other, and then finally we were able to get that accreditation. So yes, there's a system in place to try to accreditate all the labs as time goes on.
May I ask a question on the animal health side? One question more, please. Because I'm happy finally the animal health is now also inside. I have to make a confession. I am a veterinary practitioner in Kwara Kwara. Kwara Kwara. Kwara Kwara is close to Gembu, and that is in Taraba State. You know it? You know Taraba State? Everybody knows Taraba State. In Taraba State you have Gembu. You know Gembu? 100 kilometers from Gembu you have Kwara Kwara. I'm a veterinary practitioner in Kwara Kwara. And I'm called to a farmer and his chickens are dying. And I take a sample because I think it could be that he has avian flu. Could be. But I have no fridge. There is not much electricity. So I have this sample. I know from my study it has to go through the cold chain to a reference laboratory. How can this sample coming from Kwara Kwara going to your laboratory?
Well, thank you very much. Kwara Kwara, I don't think I've heard that name, but at least I've heard of Gembu. Yeah, and I know it's a difficult terrain. But what we have in all the states, every state has a veterinary department. Now, at the National Veterinary Research Institute in VOM, it's the reference lab. And I totally agree with what you said about trying to get some of these things, diagnosed at the location where the sample is taken before confirmation is done at the national level. Now, currently, for some of these diseases, it's almost impossible to say at the point of sample collection that you can have that initial diagnosis before it's sent to the reference laboratory. So now you're suspecting high-path avian influenza. Now, that has to be transported, the samples. Based on clinical signs, they might reach a tentative diagnosis, but there's no other means except to send it to the reference laboratory where confirmation can be done. So, to say that we need to strengthen that aspect of getting some of these things, at least having some level of diagnosis at the primary site, I agree. That is currently not being done for the animal sector for a lot of these priority diseases. They have to be sent using the referral system to the reference laboratory in VOM.
Very quickly, so what you have just described, you see the disease pathogens don't know about equipment. If you can work on sample network, referral transport system, and diagnostic network optimization, you don't have to bring things to Abuja. If I were you, I would concentrate probably as a priority area, strengthen the, I don't know whether they would qualify as regional laboratories to be able to enhance their capacity to test a wide range of your priority diseases. You will have killed so many birds with one stone. I wanted to suggest one more priority area, which is that I've just mentioned, establishing a working national diagnostic network optimization framework across the sectors for testing and detection of priority pathogens. I want to go to our external experts for any comments or questions to the team.
I think we still have more comments from the audience, okay, if you could take them. All right, Romy, Mike.
Okay, yeah, thank you very much. So my comment was just to respond to the question you asked with regards to whether there is any law or any legal framework for data protection. I think in Nigeria we have it, and it's in our major health law, the National Health Act. And I think if you refer to section 35 of that law, it actually clearly gives the Ministry of Health powers to establish ways data can be collected in any kind of manner and any system, which includes the National Laboratory Information Management System. Thank you.
Thank you.
Thank you, Barrister Ene. Can we have any other comments? Okay, one more at the back. 2, 3, 4. Wow.
Thank you very much. I just want to mention that with regard to the question regarding priority diseases in Nigeria, I think we have 43 notifiable diseases, but there are 10 that are of priority. Initially there were 6, but it was increased with COVID-19 and monkeypox and the new diphtheria to make it up to 10 notifiable diseases in Nigeria. Out of these, I think NCDC have been able to do diagnosis of some of these priority diseases at the subnational level, most especially measles, Lassa fever, and cerebrospinal meningitis. These have been done. Then NCDC now confirmed by doing a molecular testing, and that has worked for us. As you have just said that we do not have such at that level, but we have it at that level. Thank you.
Dr. Agogo wants to add something. Then we go to the We'll just take the last one for this round.
I was just going to say, maybe you've not mentioned much about the EDL. So how is that? That's also a best practice, and it's not really reflected. There's the essential diagnostics. And maybe my question is, how does that link, does that not reflect the conversation around the 10 priority diseases as well?
Okay. Are there other feedbacks? Okay, that will be fine. No, that's fine for now. You signify that that's okay. Maybe to the international evaluators.
Thank you so much for the presentation. I'm particularly interested in laboratory because there's an overlapping area in antimicrobial resistance and in IPC as well. There's a key indicator on healthcare-associated infection surveillance, and one of the prerequisites for that is that there is need for good laboratory system to support that. And as I have seen so far from the update from IPC is that there's a healthcare-associated infection survey not being implemented, and it's heavily reliant on laboratory systems. The coordination. So the first question is, there's a high plan which relies on laboratory systems. It's not being implemented on healthcare-associated infection surveillance for IPC, and your coordination with IPC and AMR.
Okay, so in the laboratory, we talk more about biosafety practices, which is more or less like IPC, because IPC emphasizes more on hand washing and all of that. But in the lab, we do more than that, because we want to make sure that the staff are not affected, the environment is not also affected. So there are some measures that must be put in place, especially for like biosafety cabinet, use of PPEs, hand washing, and all of that. So when we talk of the best practice in the lab, we don't really emphasize on IPC, because IPC is a tiny bit of these biosafety practices that are in place. So biosafety, biosecurity is a pillar in the ISO standard that most of our laboratories are implementing. So in biosafety also, you also talk about the facility design. So it's much more holistic and bigger than talking about IPC. So IPC is too narrow, but it's a component of biosafety practices that are in place in our labs.
Thank you. I'm not talking about IPC. I am saying there's a component on healthcare-associated infection surveillance, and you'll see it even tomorrow on RR42 in the JEE. It talks about surveillance of healthcare-associated infections in the health facilities, and for the surveillance to occur, it relies heavily on the laboratory systems, taking the swabs, testing, confirming which healthcare-associated infections are there, so that they are prevented from the patient to the health worker or from the visitors. And also it's not IPC, it's healthcare-associated infection surveillance. Thank you. And it would mean there is need for collaboration with IPC and AMR for that.
Just to make it easy. Hello?
Sorry, can I say something in respect to what the external evaluator just mentioned? I'm glad that the Director of Public Health Lab actually explained from the perspective of IPC what's happening. But with respect to the AMRO, of course, you know that you cannot divorce the laboratory services from AMRO, because it is AMRO, it is the lab services that will give you all the relevant data on the AMRO response. So what I want to clarify is there's a national AMRO plan for the country. And I'm sure, because from the agenda, I've seen something that Dr. Tochi will be presenting tomorrow. So we just decided to exclude AMRO from the laboratory presentation.
And if I have the permission of the floor to say, the country has the National Antimicrobial Resistance Laboratory Network too, that are also providing this support for the country on which we leverage on for the HCA high surveillance.
Yes.
And the National Reference Lab at the NCDC and the one in Ibadan, 2 labs for the human health, whereas the NVRI in VOM serves that purpose for animal health. And the environment colleagues also have their dedicated laboratory for antimicrobial resistance related intervention. Tracking the healthcare-associated infection surveillance at the human level is what those 2 human labs provide data on. And tomorrow, by the time IPC presentation is done, you'll be able to see more information and data in this regard on this collaboration. Colleagues from these laboratories are part of the National Laboratory System Network in this regard, if I may add. Thank you.
Thank you. Tendai, you are satisfied? Okay, so let's go back to the slide on priorities, and as we wrap up. So I think I've already suggested some additional areas as priorities that you might want to consider. And then I think I also mentioned the aspect of DNO. It's already captured. So let's go to the scores.
Just keep going back. Okay, this is
On D1.1, referral and transport of specimens is organized for some priority diseases, but may be restricted within districts or at the immediate and national level. I believe there is a lot of work that needs to go into this area, but the modest efforts that the country has made in this area, I want to believe I would qualify you to score a 2. So let's move to D1.2. D1.2, you're talking about national quality standards have been developed and implemented at the national level. Activities include licensing of laboratories in conformity with national quality standards. Yes, you did mention in your presentation that you have a national licensing agency, and you have the national quality standards, and these have been implemented at the national level. I will agree with your score to stand at 3. Let's move to 1.3. On 1.3, you're punching above your weight. So you're telling us that a laboratory system can perform nucleic acid amplification testing, bacterial culture with AST, with the QA process in place, and has some basic sequencing capacity, and the country has ability to test for all its endemic diseases and its priority diseases. And he just mentioned, you confirmed how many endemic diseases? 42, 44. 4. Endemic to Nigeria. 10. 43. Good. So what you are saying is that you have the ability to test all the 43.
ability. So
Priority disease.
No. Please. This is not for you. This is for me and them now.
So
This is what the tool says. I'm not reading my own words. And the country has ability to test for all its endemic diseases and its priority diseases. The 10 priority diseases and the 43. And this is happening in human health and animal health. Is there evidence? It's a system.
In the human health, yes. Because we are looking at the available platforms. We are looking at microscopy. So if you have look at the long list of the endemic and priority diseases, We are looking at platforms. We are looking at microscopy. Do we have the capacity? Yes. For culture? Yes. For AST? For PCR? For even serological testing? So we have that. For sequencing, yes. But for animal sector,
Yes, I think they were referring to the human health sector. And in the animal sector, the question there is the ability to test. And I can say, yes, we have the ability because all those platforms that were mentioned are available and they can be used to test for all the priority diseases.
It's okay, but you also understand, I also understand Nigeria has 36 states plus FCT, and Nigeria has human health, animal health sector, and the environment. So I'll propose a 3 for now. Let's move to the last priority area, which is effective national diagnostic network. Here we are talking about tire-specific diagnostic testing strategies existing but not fully implemented. I can't argue with this based on your presentation and the submissions that have been made. So first, before I come to you, I want to ask my external evaluators, external experts, if you agree with the scores as 2, 3, 3, and 3. Okay, you are in agreement. I want to ask you whether you agree with those scores of 2, 3, 3, and 3.
Deep 1.1. Can we go?
is it parallel 3?
Can we take it over? D1.1. 2. You're asking if you agree with this?
May I?
Yes, we agree with this.
Excuse me?
We agree with this for 2. We scored ourselves 2.
Okay. Yes, that's 1. Okay, there's agreement on indicator 1 and indicator 2.
1.2.
I think we are in agreement.
We scored ourselves 2, and I think he also agrees that we should remain on 3.
Indicator 3.
Indicator 3, 1.3. Slide 1.3, right?
So, what's the question?
Our team is proposing a 3.
3.
Instead of 4.
Do we agree with 3?
So I think what would be useful for us is to have an understanding of why you are proposing the 3 on this.
So you said they exist. And like I said, the tool as it is, of course, is limited by words. So I can say all those things exist, but Nigeria is 200 million people, 36 states, and 3 tiers of levels of laboratory system across 3 sectors. So where do these things exist?
So for the microscopic culture and sensitivity, that's almost everywhere. And then, like COVID has really helped us to develop the laboratory system. And so right now in Nigeria, there's no state in Nigeria that doesn't have the capacity for PCR. There's no state in Nigeria that doesn't have that capacity. So, but for sequencing, that is still limited.
May I think we have discussed.
Okay.
We are now finalizing. And I'm only asking if you are in agreement or not. If not, then you have to move forward to a side meeting. So,
Okay. So
you're disagreeing. You're disagreeing. So this means there will be a side meeting, but we 4.
The 1.4.
You are proposing a 3, and our external team is proposing a 3. If you are saying, now I really want a 2, then I also have to send you to a side meeting for this indication.
So we agree with this.
Okay.
But if he had proposed
Thank you.
4, we would have agreed also that we are fit to be on 4.
So concluding, you reached almost consensus. You have consensus on the priorities. They will be identified and written down and shared with you for final conduct. But on indicator 3, you need to have a side meeting. After, when you reach consensus, you may come out of the side meeting and then you can explain to the plenary what you reached.
That's fine.
Thank you so much for all
Thank you very much.
Thank you. Mr. Moderator,
yes, sir.
Before you go on, there is another group on R5, risk communication.
Okay.
I sent to a side meeting.
Okay.
They came out, they have consensus.
Okay.
So I would like to hear from the team lead, the Nigerian team lead, and the external team lead,
all right,
what the consensus is.
Okay.
So may I ask Fischel?
All right, let's have the Nigeria Risk Comms lead. Do we have the Nigeria Risk Communication team lead in the house? Risk communication, okay, is there. Then the evaluators. The floor is yours. Let's quickly get our feedback. Sorry, we are still in section. Can we please reduce the conversation? Thank you. Over to you, please.
Good afternoon once again. We actually reviewed the criteria for this course, and we agreed that we should remain on 3. We should drop that back to 3 on account of the fact that it will give us opportunity to explore resources to be able to strengthen whatever level we have at both national and sub-national level. However, we feel the word adequate needs to be clearly defined, maybe in the footnotes, because it's a relative thing and it can be controversial. And then, or maybe they change the word. So that's our recommendation, and they said they will get back to people who develop the tool. Thank you very much.
Oh, thank you. Thank you.
Okay, so we have an agreement. Do we have any pending side meeting outcome? Okay, so it's only left with the laboratory systems. Sure. I'm not sure we're able to get the feedback from the lab team today. But I think we really need to give the lab team a better round of applause for being on their feet for 82 minutes. That's the longest we've had so far. Very thorough section indeed. Thank you, everyone. All right, so thank you very much, Dr. Eric, for the great coordination again today and all the evaluators. But before we go, we'd like to hear from...
Mr. Moderator, I think you are forgetting a technical area.
No, we are done for...
Okay. Okay. I wasn't aware of this.
So we actually... This is past 5. Let's get back to the apologies. We need to hear from our observers, national observers for today. So far, Prof.
So, good evening, everyone. It's been a very long day. We want to commend all the participants for today and all the stakeholders, including the external evaluators. Today has really been very vigorous, and we would like to say that the process actually is very credible, very incisive questions, and the presenters also have come across, many of them came across as very eloquent and understood very clearly what the mission is all about, and were able to provide evidence for and to argue their case. But more importantly, we think that the priority actions that we had consensus on are such that will move the country on a sustainable trajectory to being better prepared to prevent, to detect and respond to events and situations that can pose a threat to both national and global health security. So we want to commend everybody. It was a very credible process, and we think we are all happy with the consensus that have been reached. Thank you very much.
All right, so just to inform us that we are not able to continue with other presentations today, and tomorrow, please, we'll be starting by 8:30 with the legal instrument team, and we take the remaining tomorrow before we wrap it up for them. Okay, Professor Richard, he said he doesn't believe we'll be here by 8:30. Does that mean Nigerians don't keep to time? We do. So we're going to prove it tomorrow that we keep to time. Do I have your backing? Okay, Dr. Eric, let's have your closing thoughts first.
Mr. Moderator, thank you so much. And first of all, I would like to thank the team of observers for their very kind words, and also for your patience to sit here the whole day. And I'm sitting there the whole day, so we look at each other, and I can see that you are in full attention the whole day. So a big applause for the team of observers. And I also would like to ask you to give a big applause to yourself, because you are all very active, attentive, listening to us. And then, of course, we have to applaud those who are supporting us in doing this. The technical people in the back, the professionals. The people from the hotel, from the excellent food. And, of course, Professor Moderator. And the team moderator, yes. I wish you all a very nice evening, and we will have to write our reports, and we will be back here tomorrow at 8:30. I'm not sure if Richard will be awake by that time, but I try to do my best to keep him with us as well. Thank you so much.
All right, thank you very much, the team lead. Thank you very much, the evaluators, and thank you everyone for the great outing today. You agree with me that Dr. Henrik has been very phenomenal so far. This is the second day of this meeting, and I think he deserves a better round of applause. Thank you so much, everyone. All right, so please, again, tomorrow, 8:30. And it's important that we start at that time, because we have 6 technical areas left, and the team will be traveling tomorrow. Member of the team will be traveling tomorrow for the field visit. So it's important that we finish early so that they can proceed to other engagement. So thank you very much, everyone. I'm wishing us a very pleasant evening. Thank you very much. Good night.